welcome to day 2 of the conference. I am Shravya, currently working as an intern in Subbaya Medical College. I'll be your host for today. I hope you all had a refreshing start to your day. Now we continue today's scientific sessions with a topic that addresses one of the most prevalent changes in modern healthcare, that is obesity. We have our speaker, Dr. Praveen Devarbavi, MBBS MD, a renowned consultant endocrinologist from Shimoga, to deliver the talk on topic Pharmacotherapy of Obesity, Current Trends. Now, I welcome chairpersons for this session, Dr. Priyadarshini Baiji and Dr. Kalabharati HL, to join us on the dais. Dr. Priyadarshini Baiji is currently working as Professor and HOD in Department of Pharmacology at Siddhaganga Medical College and Research Institute, Tumkuru. Dr. Kalabharati HL is currently working as Professor of Pharmacology at JSS Medical College, Mysuru. We are privileged to have both of you with us today to chair this session. Now, I request the chairpersons to introduce the speaker, Dr. Praveen Devarbavi.
Bhavi. He is a renowned consultant endocrinologist from Shimoga. He is currently working as professor in the Department of Medicine, Subbaya Institute of Medical Sciences, Shimoga. He is a medical director of Devarbavi Endocrine Diabetes Center. He has around 15 years of experience in diagnosing and treating endocrine disorders. He has been instrumental in establishing the first endocrinology and metabolic disorder center in Shimoga and Malnad region of Karnataka. And he has dedicated to the comprehensive management of hormonal diseases. With over 22 publications, multiple clinical trials, and active participation as a speaker at national and international conferences, Dr. Praveen Kumar is widely recognized for his clinical excellence and academic contributions. Over to you, sir.
Organizing Chairman, Dr. Lingappa sir, and Dr. G.K. Mahesh, and Organizing Secretary, Dr. Abhishek, for having me here and giving me this opportunity to be with the august audience. Today I am going to speak about pharmacotherapy of obesity, the current trends. So you all know that today the global prevalence of obesity, this is 988 millions. So you might have understood by this time now that obesity is a big burden throughout the world. And the US leads the world with the highest number of obesity. China is the second, and third is India. Now, it is a state of excessive adipose tissue mass in the body, the obesity. And it is a separate disease entity rather than mere risk factor for cardiometabolic disorder. And it is a chronic condition. Initially, patient will have a weight gain over a period of time when they develop a particular weight and the set point is set, and then it becomes plateau. It is very difficult to reduce the weight or increase the weight also. So obesity is also a relapsing condition. The weight regain occurs if the initial weight loss, whatever the method you do to reduce your weight, whether you are going to do an intensive lifestyle modification to reduce the weight, after initial weight loss, you are starting, after some time you regain your weight. So this is the problem. Even with the bariatric surgery, patient will regain some weight after some initial period of weight loss. Therefore, short-term changes or short-term treatment for obesity will not change the biology of the obesity or whatever drives the obesity, and after some time patient will try to gain the weight, and it requires a long-term treatment, sustained treatment. So we are in search of medicines or any other surgical intervention so that patient can maintain weight loss for a very long period of time. There is something called as obesity MHO. That is, MHO means recently the obesity nomenclature has started changing. Metabolically healthy obesity, and also there is something called as metabolically unhealthy obesity. These terminologies over a period of time may not take much importance, because even a metabolically healthy obesities have in long term going to develop a cardiovascular disease. So we all need to know why obesity is important, because it is associated with the comorbidities. Most of our obesity treatment is not only targeting the weight reduction, but also to reduce the comorbidities associated with the obesity. The obesity has got a mental comorbidities in the form of depression, anxiety, and panic disorders. It can have a cardiovascular adverse comorbidities like atherosclerotic cardiovascular diseases, hypertension, atrial fibrillation. Atrial fibrillation, many obesity, if the patient comes with obesity, if the patient has atrial fibrillation without any underlying cardiac disorders, it is a cause itself is obesity. Heart failure. Obesity has become a major reason for a heart failure today. It can cause metabolic disorders like type 2 diabetes, fatty liver diseases, dyslipidemias, gallstones. The obesities are associated with the gallstones and the gout. There are several malignant disorders are associated with obesity, particularly colon and breast cancers. It can cause some of the musculoskeletal disorders like osteoarthritis. Obese people will have early osteoarthritis. They can have a physical impairment and back pain. Low back pain is a very important and most common disorder associated with obesity. It can affect the reproduction in the form of male infertility, hypogonadism and PCOS. So it can also cause recurrent urinogenital infection, incontinence, pulmonary disease like sleep apnea. Obesity is a major reason for obstructive sleep apnea and asthma and COPD. So why I wanted to highlight about the comorbidities is, whenever you are managing a diabetes pharmacotherapy, any guidelines, it is not just based on just a weight. It is weight associated with the comorbidities. Patient need to have one or the other comorbidities after 27 BMI to initiate one of the metabolic intervention in diabetes, so obesity. So you need to know that lifestyle modifications, this is a look-ahead study for obesity in 2014. You can see there is an initial significant weight reduction of almost 8.5% with the intensive lifestyle modification itself. But what happens after some time? After 1 year, patient slowly starts gaining weight. Why does it affect? Even after maintaining intensive lifestyle modification, does he fail? Does he not active? Does he not doing enough? He is doing all the things to reduce the weight. Whatever he has done for the first year, he maintained it, but still he gains weight. Of course, this is going to have a lesser weight than the placebos, but still they start to regain weight after 1 year, even after the intensive lifestyle modifications. On the other hand, even with the DPP trial in the Lancet, it was in a type 2 diabetes, you can see, the lifestyle modification has a very good weight reduction initial 1 year, but over a period of time, patient starts gaining weight. Because why it happens? It's because there is something called as hormonal adaptation which occurs in our body to regain the weight, even after intensive lifestyle modification. Initially, they will have weight loss. After some time, they gain weight. This is because our brain has set for higher. There is something called as a set point for weight. If the higher set point is kept for the higher weight, whatever you do initially, the patient will start regaining the weight because of the hormonal, what is called as adaptation. See, this is ghrelin which causes hunger. The ghrelin starts increasing in the body so that patient will start gain weight. As soon as the patient loses weight, the ghrelin will increases. Over a period of time, ghrelin causes more and more hunger. There are satiety hormones called as leptin, amylin, CCK, and peptide YY. These hormones will reduce. They are supposed to cause fullness of the stomach, satiety. They also decreases. So therefore patient starts gaining. So body will not allow for a particular set point of weight to come down because it will do all the things from the hormones to maintain that weight. That is the reason initial weight reduction with the lifestyle modification, patient starts gaining weight. So why people living with obesity need pharmacotherapy? The obesity is a progressive disorder. It is centered in the brain and influenced by the complex interaction between inherited genes with the complex environmental factors. And weight loss achieved with a diet, physical activity and behavioral modification limited and is difficult to maintain. So maintenance of the weight loss is challenging due to the metabolic adaptation. Therefore, pharmacotherapies are needed and we are searching for the pharmacotherapy which causes weight loss efficiently. And it is the long-term safety should be there and the weight loss maintenance should be there for a long period of time to reduce the complications. So what is the FDA approval criteria for anti-obesity medications? These are standard guidelines laid down in mid-90s. The newer drug must induce statistically significant placebo-adjusted weight loss of more than 5% for a period of 1 year. And more than 35% of those who achieved more than 5% should maintain this weight reduction. So this is the criteria for anti-obesity drug laid down by the FDA, so that every drug which reduces the weight may not fit into the obesity pharmacotherapy. So medical treatment of obesity and the principle, the anti-obesity medication affects the we need anti-obesity medication which affects the pathophysiological pathway which leads to obesity. And both, it should not only reduce the weight, also it have some effect on the comorbidities like diabetes, hypertension, dyslipidemia. It should have some beneficial effect on that. Is the Endocrine Society guidelines in 2015. So when you start pharmacotherapy, this is a BMI between 25 to 26. You should go for intensive lifestyle modification. No pharmacotherapy or surgery is required. Indians require even lesser BMI compared, because Indians are more obese at the lesser BMI. So we have a separate BMI for Indians. Between 27 to 30, if the patient has not only should do a diet and exercise, which is not sufficient to reduce the weight. You need to have a pharmacotherapy if there is a comorbidities. And if the patient is more than 30 BMI with 30 to 35, pharmacotherapy is a compulsory along with the lifestyle modification, because you will not be able to achieve the good amount of weight with the lifestyle modification alone. And with the 35 to 40, with comorbidities, patient can undergo even bariatric surgery. More than 40, probably pharmacotherapy and bariatric surgery both are needed. See, this is the eating pleasure is a major contributor for obesity. You can see there are two pathways in the brain to maintain the balance of energy. The homeostatic pathway is actually the original pathway to maintain the energy balance. So whenever you are hunger, then those hormones required for hunger will decrease and the patient will increase and patient will start eating. Whenever stomach is full, patient will stop eating. This is called as homeostatic pathway. There are other pathways which are responsible for this obesity is called as hedonic pathway. Hedonic pathway is nothing but pleasure eating. So you get a pleasure after eating. This is mainly the dopamine and serotonin pathway which are involved in it. So patient will do snacking. Some patient who are anxiety, to elevate the anxiety, they start eating. Therefore, dopamine and serotonin pathways are targeted in obesity. Because these hedonic pathway overtake this homeostatic pathway, the patient will become obese. So these are pharmacological options for weight management. The FDA approval present medications and DGCI approved present medications for approved obesity is orlistat, phentermine and topiramate, naltrexone and bupropion, and these are the probably now I'm not going to talk much about these drugs because these are the older drugs. I'm going to talk about the newer drugs. Liraglutide 3 milligrams is a GLP-1 analogs. Semaglutide 2.4, also called as Wegovy, which is a very famous drug which has changed the management of diabetes recently. Tirzepatide, Zepbound or Mounjaro, which is recently available in our market, India. And setmelanotide and metronidazole, these are the only for monogenic obesity. You look at these, the mode of action. The most of the drugs are targeting on the brain to reduce the appetite. The rest is only one orlistat which has got energy stage which acts on the periphery, rest of them in the brain. Predominantly in the brain, they have some good effects on the pancreas and GI tract. So, does it mean that only this much of drugs in the market? No. There were so many drugs came to market, they went because of the various reasons. You can see these are the drugs which were in the market. Rimonabant, you might have heard about Rimonabant actually. 2006 it was approved and it was withdrawn from the market in 2007 because there was an increased incidence of depression and suicidal tendency. So many drugs which were targeting brains were withdrawn from the market because of the cardiotoxicity or the patient had a suicidal tendency, some psychological disorders, etc. These are drugs, orlistat, phentermine, naltrexone. I'm not going to speak much about these drugs because they have a weight reduction up to 5% to 6% of body weight. Okay, not beyond that, and not everybody, because I think there are many practitioners here. Orlistat we have used in many patients. We don't see much weight reduction as it was shown in most of the clinical trials. So now, mainly my focus will be on the hormones which are produced from the GI tract, that is GLP and GIP. And this GLP is a target of today's talk. It's a single agonist we have, that is a GLP-1 receptor agonist, amylin analogs, PYY agonist. There is something called as a dual agonist, GLP and GIP receptor agonist, synthetic glucagon, GLP and glucagon receptor agonist. And we have a triple agonist in a study, which has this is in the phase 3 trial, that is a GLP, GIP and glucagon. So this is a GLP-1 receptor analog. So this GLP is natural GLP is in the body for hardly 10 minutes because it gets destroyed. So prolong its action, we have modified this GLP by two methods. One is we have attached this to an albumin And also we have modified this GLP so that it is not breakdown by the DPP4 inhibitors, the DPP4 enzymes, so that its half-life is prolonged. So from 10 minutes to 1 day to 1 week, we have a drugs now, GLP-1 analogs, which can act for nearly 1 week. So the mechanism of action of GLP-1 analogs are, it acts on the brain, it reduces hypothalamus level, it reduces food intake, reduces reward behavior and palatability. At the liver, it causes gluconeogenesis and steatosis, reduces steatosis, and intestine gastric emptying and decreases gastric emptying and gastrointestinal motility. At the pancreas level, it improves the insulin secretion, insulin synthesis, glucagon secretion, is decreases apoptosis of the pancreatic beta cells decreased, and at the muscles level, it also reduces insulin resistance. So this is the first GLP-1 analog approved for the obesity, liraglutide. In 2014, FDA approved this drug in the market. We are using daily the GLP-1 analogs, GLP-1 analogs daily for a diabetes patient. In India, it is available, highest dose is 1.8 milligrams injectable form. It is called as Victoza. The Victoza 3 milligram liraglutide is for obesity. See, in diabetes, most of these drugs, GLP-1 was started for diabetes, to control diabetes. Over a period of time, what they found was not only it controlled diabetes, it also reduced weight in diabetic population. And with this, what they started doing is, they started doing exclusive trial on obese patients without diabetes, but the much higher doses, because at the diabetic doses, it did not reduce much weight. The weight reduction was around 3 to 4%. When they used at a higher doses in obesity patient, they got a drastic response in their clinical trials. So this was liraglutide. The study is done in obesity with the 3 milligrams. For diabetes, we give maximum 1.8 milligrams. This is called scale obesity trial. So it reduced somewhere around 7 to 8% of the body weight. So this was in that time, it was a great news from us from US that 3 milligrams of liraglutide reduced around 8% of the body weight in obese patient. But it was not available in India. The available maximum dose in India was 1.8 milligrams. So you might have heard the celebrities started speaking about GLP-1 analogs. So suddenly GLP boom went up in last 5 to 6 years because of these celebrities. They started using GLP-1 analogs for their body weight reduction for various reasons. So the drug also became a celebrity. This is semaglutide 2.4 milligrams. It is called as Wegovy, the drug responsible for hope as well as the hype in the obesity management. So when this drug introduced, the Novo Nordisk, this is by the Novo Nordisk, the Novo Nordisk stock market gone up, it shot up in the market. And at one time, the Novo market, the Wegovy, the evaluation was done, and it was more than the GDP of the Denmark. The Novo Nordisk is in Denmark, the industry is in Denmark. It supplies all insulin as well as this obesity drug. And the obesity market is so big that it overtook the GDP of Denmark, the evaluation of this one company, Novo Nordisk at that time. And it's a once a weekly injectable GLP-1 receptor agonist. The 0.25 to 1 milligram is dosing for diabetes. In diabetic trial, we found that it reduces significant amount of weight reduction. And 2.4 milligram is a drug, that is a maximum drug through titration, is responsible for weight reduction. And the weight reduction is almost 16% of the body weight. So if the patient has 100 kg, he will reduce a 16 kg. It is a mean weight reduction in the clinical trials. Some patient can have a 30 kg weight reduction, 40 kg weight reduction, that is different. But a mean weight reduction in a clinical trial is a 16% of the body weight. So this trial called as step trials, step 1, step 2, and a step 3 trial. Step 2 is diabetes patients, step 1 and step 3 is for only obese patient. The next drug which came to market was tirzepatide, is also known as Japon, and in India it's a Mounjaro, GLP and GIP agonist. It is also once a weekly injection. Tirzepatide trials focused on diabetes called as SURPASS trial. In SURPASS trial, they found that weight reduction in diabetes patient was 11 to 14%. So they did an anti-obesity trial, that is a phase 3 trial for tirzepatide called as SURMOUNT trial. With a dosing of 5, 10 and 15 milligrams, they found that weight loss was 20%. So this is like, these drugs came to market, they did a trial, and it is reaching almost to the bariatric surgery weight reduction. The bariatric surgery, you know that the weight reduction starts with the 25%. So now the 25% mark it is reaching with the tirzepatide, which is presently in market in India. It is June, it was approved in market. We have started using it in the brand name of Monjaro. It is in India since June, and the Wegovy is in India since March 2025. So both are available in market in India. So it is also approved, tirzepatide is also approved for obstructive sleep apnea syndrome. It reduces significantly obstructive sleep apnea and obesity. So the tirzepatide, initial all trials, this is what you are seeing. The yellow bar is for 15 milligrams of tirzepatide. So this is a SURPASS trial. SURPASS trial, you have a maximum weight reduction of 11%. You might have, you may say why there is a difference of this in obesity trial versus diabetes trial. Diabetes trial is included all patients, like more than 25% BMI, 25 BMI. But in obesity trial, they include a patients of BMI of more than 30. So higher the weight, more the weight reduction. So in the SURMOUNT trial, it is a 20.9% reduction with the tirzepatide dose of 15 milligrams once a weekly subcutaneous injection. These are SURMOUNT trial result. You can see up to 20.8% when it compared to the placebo. So a patient of 100 kg will have a 20%, 20 kg weight reduction, mean weight reduction they can have. So with this, there is a fight between two giants now, Novo Nordisk and tirzepatide is by Eli Lilly. So when Eli Lilly announced, it's it's a stock market. There was a fight between in US stock market with Eli Lilly versus Novo Nordisk. So Novo Nordisk thought that we are 4% to 5% less than the tirzepatide. They wanted to do a trial. They did with a higher dose of semaglutide, that is 7.2 milligram subcutaneous injection. This is called a step-up trial. The step-up trial is a semaglutide 7.2 milligram subcutaneous injection. They compared and they got an weight reduction of 18.7% of semaglutide injection in SURMOUNT when compared to SURMOUNT 1 trial. So it is almost near, and they reduced the gap between the tirzepatide versus semaglutide, the competition between Eli Lilly versus Novo Nordisk company. So these are what in India we have these two drugs, that is tirzepatide and Wegovy, which is the highest weight reducing drugs presently for obesity patient. Other drugs are oral semaglutide, Rybelsus. In India we have oral Rybelsus for diabetes patient. Now there are trials which is going on for obesity with a higher dosage. I said it requires higher doses for obesity. Other drugs which are there is oral GLP, which is synthetic GLP, GLP glucagon dual receptor agonist, GLP plus GIP glucagon triple receptor agonist. Though these other glucagon and GIP will have additional benefit apart from the GLP. And cagrisema is a cagrilintide with a semaglutide. There is an amylin derivative with a semaglutide trial is going on. This is oral semaglutide. Oral semaglutide has this is a peptide, right? The GLP is a peptide. As soon as it enters the stomach, it gets destroyed in minutes because of the acidic pH as well as the proteolytic enzymes. So it is coated with some technology called SNAC technology. So this is the first oral drug available in the market, the one peptide. Because of this technology, in future, insulin may become oral over a period of time. That is how the technology for insulin is also. This SNAC technology is, there is a layer with a SNAC which covers this GLP analogs, enters the acidic pH. It neutralizes this acidic pH around this semaglutide. And also reduces proteolytic degradation of this semaglutide, and also helps in the transcellular absorption of the semaglutide across the stomach. This is how oral semaglutide is absorbed. Through SNAC technology, this is called as Rybelsus. So naturally, when you eat these GLP-1s, the only 0.01% is the bioavailability. Now, when you use this SNAC technology, 0.1 to 0.4 will be the bioavailability. And with using this much bioavailability, they started doing a trial that is called as Rybelsus. Pioneer trial for Rybelsus done on diabetes have shown weight reduction of around 3 to 4 kgs. And if you look at this other drug, that is empagliflozin, which is 25 milligrams, also reduces almost 3 to 4 kgs in clinical trial. But this is not included. Oral Rybelsus of 14 milligrams, which is a maximum dose for diabetes, is not included in obesity. This is higher dose was required to reduce more weight to come into the anti-obesity. So this is called as Pioneer Plus trial for oral semaglutide, which used 14, 25, and 50 milligrams of semaglutide. So this is also Novo Nordisk company which produces this. And with the 15 milligrams of semaglutide, 50 milligrams of semaglutide in Pioneer Plus in diabetes patient, they found around 8% of weight reduction. So for that, they went to exclusive trial of oral semaglutide called as Oasis trial. 50 milligrams of semaglutide in Oasis trial, they found that 15% of the weight reduction. Now you can see, I just discussed Wegovy, which is an injectable semaglutide, also reduced to 16% of weight reduction. Now you have oral drug, which is a GLP-1 drug, which can reduce the body weight of 15%. So you can look at the result of the trial. Is more than 10% weight reduction was seen in 2/3 of the patient. Half of the patient had more than 15% reduction, and up to 1/3 patient had more than 20% reduction with the oral semaglutide alone. Now this is under the FDA approval. Now you might have seen the 50 milligrams is not in the FDA approval right now, because they have applied for 25 milligrams for FDA approval, for a reason that 25 also reduces up to 13 to 14% of the body weight. But they wanted first 25 milligrams for approval, then 50 milligrams of approval, because of side effects can be reduced with the higher doses. So we have survodutide. This is a synchronized trial, which is a GLP and glucagon dual agonist. We have a triple agonist called retatrutide, GLP, GIP, and glucagon receptor agonist. This is the one drug which is presently undergoing a clinical trial. It is very potent anti-obesity medication at present. Among the clinical trial, presently it has got a highest amount of weight reduction, that is 24% of weight reduction. This is retatrutide. This is a phase 2 trial. Phase 3 trial is going on for retatrutide. Probably this will be in a market with a big hit. So warfaglipron, this is a novel oral non-peptide this is a oral GLP analogs. It is a non-peptide, so it is not destroyed easily by the stomach pH. And in the clinical trial, it has shown that phase 2 trial 14.7% weight reduction. That is Attain-1 trial is a trial which is they are doing it for the phase 3 trial. Probably it will be in market soon. And this is about the warfaglipron is a small, better absorbed, viability is 20 to 40%. You can see viability of semaglutide is only the 0.1 to 0.4% with a snack technology. It don't need a co-formulation with absorption. It doesn't interact with the food. So the amylin analogs, because amylin, the mechanism of action is amylin increases the satiety, the fullness of the stomach, and also it affects the hedonic pathway, which I was talking about, that it reduces the feeding reward neuro circuits. So this amycretin is an amylin, this synthetic drug is presently in the phase 1 trial, and probably they will enter into phase 2 trial. In a phase 1, it has shown that it is 13% weight reduction. This is the drug again by Novo Nordisk, cagrilintide. This particular drug is a combination of the cagrilintide, that's amylin derivative, the amylin analogs, with the 2.4 milligram of semaglutide. This combination is given to have a more weight reduction other than getting the weight reduction what you got from semaglutide 2.4, that is Wegovy. So again, there is so much competition in getting more weight reduction so that they will have a more market in, because this is the biggest market presently is among non-communicable disease is obesity. You have to accept it. Cagrilintide phase 3 is a redefined trial. The top line news was the people with obesity, overweight with one or more comorbidities, 68-week trial have shown 22.7% weight reduction presently. So this is a phase 3 trial. So with this, because they claimed, the cagrilintide, the Novo Nordisk claimed that it is going to have an 25% weight reduction. Initially, the stock of Novo Nordisk went high, but after the result, it is just 22%. It did not cross the 25% mark because of this hype was not fulfilled. The share price of Novo Nordisk crashed to 24%, crashed by 24%. This is in the market. So they have redefined 2 obesity with diabetes, redefined 3 obesity with the cardiovascular disease, redefined 4. This is a clinical trial for cagrilintide. Versus tirzepatide head-to-head trial is going on. That is a redefined 4. These are the trial to show what is the difference. So finally, so this is how the anti-obesity presently it is going to be in future. So the GLP-1 analog is the center of anti-obesity treatment. That is, it decreases food intake, increases satiety, increases insulin secretion, reduces glucagon, and gastric emptying. Along with that, if you add GIP agonist, it becomes terzepatide. That is what happened actually. Terzepatide is nothing but GLP, GIP. Again, GIP, what it does? GIP agonism causes decreases food intake, increased satiety, increased insulin secretion, lipid buffering capacity. If it is a glucagon is added to it, it becomes a triple agonist. So the GLP, GIP and glucagon agonist will have another 2 to 3% of weight reduction. Amylin agonist is cagrisima when it is added to GLP-1. PYY agonist, there is a drug is presently at the study. GIP antagonist, antagonism also helps in this one. It is added to GLP-1 analogs. These are probably is going to be the basket of drugs in future. So we need to know a little bit about the side effect profile of our drugs which we are using right now. That is Wegovy or injectable semaglutide. 20 to 30% have some side effects. The nausea is present in 38%, diarrhea in 26%, and vomiting and constipation. So you might have, with this you may say how the patient will use with such a high number of side effects. But if you look at the green bar, they are very mild symptoms. And over a period of time, these symptoms are going to subside, and there will be a set point set for these symptoms. And semaglutide, the clear-cut contraindication is pregnancy and lactation, and also the patient with the family history of MEN and medullary thyroid carcinoma. You should be very cautious in using it in pancreatitis. But rather I say don't use it in pancreatitis, because there are previous studies which shown that GLP-1 is having pancreatitis. It causes gallbladder diseases, therefore you should be very cautious, screen for gallbladder diseases initially. And diabetic retinopathy, because you might have seen there are a lot of lawsuits were done against semaglutide because of the retinopathy or worsening of loss of vision. It is only in diabetes who are not screened. Severe diabetic retinopathy, it can worsen very rarely, and it is because of the rapid control of blood glucose with the semaglutide. Available option presently in India, which reaches more than 10%, is semaglutide, and terzepatide is almost crossed 20%. We are yet to reach 25% of bariatric surgery with a 3 to 4%. I am very sure that in future we are going to have a drugs which is going to be as equal as the bariatric surgery. So this is an approach for treatment of obesity. You can see that CVD with the DM, Lira, Orlistat, because it is a clinical. Only thing is you need to know there are some drugs with a patient with anxiety disorder or psychiatric disorder. You can give the older drugs like naltrexone and bupropion. Rest of the drugs requires GLP-based therapy only. Whether they have NAFLD, obstructive sleep apnea, the patient with uncontrolled diabetes, hypertension, and cardiovascular disease. The drug of choice presently for obesity is GLP-1 analogs. Presently, they are very expensive drugs. Presently, we have each Wegovy costing a monthly price of around 17,000 to 24,000. And in December, it is going to lose its patency. And there are a lot of Indian drug companies come with biosimilars which have a price of around 4,000 to 5,000. In conclusion, it is an actual pandemic of the century. Options recently available in India is at present address the problem effectively in a majority of the cases. And agents available has ignited the fire and hope in the management of obesity. The result of phase 2 and 3 trial of semaglutide related terzepatide, retatrutide, cagrisima, survodutide, and other drugs definitely are effective. They are safe, and they are effective treatment for long-term obesity management. Newer therapies have explored enthusiasm, gives hope to the patient. Hype is created by the pharma industry, by commercial stakeholders. Thank you so much for a patience hearing.
I think it was a wonderful. Most often we are coming across with obesity among younger kids.
Okay. Presently, there are no medications approved for 12 to 18 years of age with the adolescent for weight reduction. Apart from that, there is no other anti-diabetic medications approved. For 12 to 18 also, Orlistat is approved with the lower doses, 60 milligrams thrice daily. Apart from that, no medications are approved. Intensive lifestyle modification is the only left option for younger than 12 years of age.
Audience?
BMI is perfectly normal, but they have abdominal obesity. So is there anything like that for anything?
Yes.
Where that will be given like it's okay. If BMI is normal and he has an abdominal obesity.
Yes, absolutely the correct question. because it is very pertinent to the present scenario in India. Indians are called thin fat Indians. What is thin fat Indian? This is something called as YY paradox. YY paradox means we have, say, Indian having a BMI of 25, and a Western having a BMI of 25. So when they have undergone the perfect method of this body fat estimation called as DEXA, it was shown that Indian had more visceral adiposity as well as abdominal obesity compared to those patients who are having a similar weight. So you come to a non-obesity range of mark for Western, that is 23. 23 is non-obese in a Western. Indian still had obesity at the central part of the body, that is visceral as well as truncal adiposity. So that indicates that Indians are thin fat Indians. That's why Indians actually have more obesity at the viscera and more obesity at the center because of the many other reasons. There are thrifty gene hypotheses, various hypotheses. Because of that, even at the, if you are thin, you are going to have obesity at the, that is the reason the guidelines of Indians have brought down this BMI mark to not 25 and above, it is a 23 and above. 23 to 25 is overweight. 25 and above is called as obesity in India at present. So the guidelines have changed 2 steps less for Indian guidelines. Whatever I spoke is the Endocrine Society guidelines for Westerns, where the 27 plus comorbidities need pharmacotherapy. It is a 25 plus comorbidities in India requires pharmacotherapy. So you can think that you have to reduce the BMI mark cutoff for Indians. This is basically because what sir has said, there is a thin fat Indians because of the visceral obesity. Because because Indians used to face a lot of famine and loss of droughts, where whatever we eat, our genes used to store fat in the viscera. So that immediately after sometimes we are going to face the famine, so that we can spend this energy. But it did not happen in after last 5 to 6 decades in India because of the economic development. We never faced famine, food available everywhere. So whatever we ate, we started gaining, or whatever we start storing in viscera. That's why Indians started having obesity at the viscera as well as abdomen.
As I said, all the studies you showed there, they took BMI as a reference point to define obesity or normal weight, whatever it is. But why they don't take the better indicators of obesity like waist circumference, waist hip ratio?
All these trials have shown not just BMI. All the trials have done based on the waist circumference, waist hip ratio, as well as the BMI. There are some trials have taken not one step ahead. They have taken DEXA as the measure for estimating the body fat estimation. They have done one step ahead. All these trials have taken waist circumference, waist hip ratios, height hip ratios, and BMI. All the trials. The latest trial, we do not have BMI at all. This is not based on BMI at all.
Are there any studies?
And they have done what is that, impedance, either impedometry, that is the impedance you see in the gyms and all, you get that impedometry where you get ultrasonic waves estimating this, or comparatively is DEXA. The DEXA is a gold standard for estimating body skeletal muscles, skeletal as well as body fat.
Sir, good morning. It's a very basic question. So once the patient is diagnosed as obese, so when we need to start the pharmacotherapy, all the molecules which you have told, can you briefly tell about that, sir?
Yeah, that's what I was showing one of the slide, Endocrine Society slide. Okay. That is when you are 27 plus comorbidities, you start pharmacotherapy. If it is 30 plus, you are starting lifestyle plus pharmacotherapy. If it is 35 plus, lifestyle pharmacotherapy and bariatric surgery with comorbidities, if it is there, bariatric surgery. And if it is more than 40, bariatric surgery is probably the most effective way of reducing body weight.
Sir, if the BMI is around 23, 24?
That's what I said. For Indians, you can reduce 2 steps less.
Yes, yes.
You can still go, if the 23 to 25, if you have a comorbidities, pharmacotherapy. If you do not have comorbidities, go for intensive lifestyle modification.
Yes. Thank you, sir.
Comorbidities are listed. I just listed all comorbidities from brain to heart, all the comorbidities.
Any more questions? Thank you, sir. It was an enlightening talk, and you have highlighted the practical implications of the latest therapeutic options. Thank you very much.
Thank you so much, ma'am. Thank you.
Now I request Dr. Praveen Devarabhavi to hand over the memento to the chairpersons, Dr. Priyadarshini Bhai ji, and Dr. Kala Bharati HL.
In transforming how we learn and teach medicine. We are privileged to have with us Dr. Radhika Sherkane, Professor and Head of Department of Pharmacology at SDM College of Medical Sciences, Dharwad, to deliver a talk on the topic AI in Medical Education, Transforming Learning and Teaching. We welcome you on the dais, ma'am. Now I welcome chairpersons for this session, Dr. Deepak P. and Dr. Sarala N. on the dais. Dr. Deepak P. is currently working as Professor and Head of Department of Pharmacology in Hassan Institute of Medical Sciences, Hassan. Dr. Sarala N. is currently working as Professor and Head of Pharmacology and Director of Academics at Sri Devaraja's Medical College, Kolar. We are privileged to have both of you with us today to chair this session. I request the chairpersons to introduce the speaker, Dr. Radhika Sherkane.
Good morning. It's my privilege to introduce Dr. Radhika Sherkane, currently working as Professor and Head of the Department of Pharmacology at SDM College of Medical Sciences, Dharwad. With over 23 years of post-MD experience, Dr. Radhika has served in key academic and administrative positions since 2002. She has 23 publications in her name in various journals. She is an approved undergraduate and postgraduate guide, coordinator of the Medical Education Unit and Pharmacovigilance Committee, and serves on several editorial boards and ethics committees. She holds additional qualifications in clinical research, rational drug use, and advanced medical education, and chairperson of the Institutional Animal Ethics Committee at SDM-CMSH. Her contributions to medical education and pharmacology research are significant. She has received various research grants and awards for best papers and presentations. Now over to Dr. Radhika, ma'am.
Thank you, sir. Still, a very important, undeniable part of our present. So I will be talking about artificial intelligence in medical education, transforming learning and teaching. Now, if I had to say that since we are interacting since yesterday, most of us have graduated in our 1900s. We were undergraduate students during those days, and we remember our undergraduate days something like this. That is, we were surrounded around the cadavers in our anatomy halls, and we proceeded from there to learn anatomy and various other subjects. We were in the labs too. But then the transformed day of today has undergraduates around an artificial machine, or a machine which does serve the purpose of our dissection hall without a cadaver, that is an anatomage table. So to say, so many revolutions have taken place in medicine. We have moved from only stethoscope now to stethoscope with simulation. We have mannequins and all of those who can teach us, just like what we did with our patients before. We also have moved from just chalk and board to chat bots now. So my session today will tell you something more related to these, especially with our subject also, that is, we have moved from, remember those days of quarantining dogs and equipment settlement for our experiments, to our computer-assisted labs. We just had a short duration of experience with our CAL labs, and very soon the future is here, that is, we have personalized AI tutors. So this topic takes you through these few developments. Instead of making it very theoretical, I have just added a few practical points from my side, such that immediately once you are out of this seminar hall, or I say conference, you can actually start using them. We actually have to dive deep into this. You will know once I go through it. With the disclaimer, I begin that whatever I am presenting in the session today is just my experience of things that I have been trained for and I have handled before, but it does not guarantee that this is how it actually works with every one of us. It differs with perception and also with the professional judgment. So I have converged the whole discussion into 4 aspects. The first 2 just being the basics of AI. Because I cannot directly jump into that to make all of you relate to what I'm saying, I have just put on a few basic points on what is AI, how it evolved, what are the subset and types, and how are we going to use them in our profession. The third actual point, the objective of the session, is what is your take-home message from my side. That is some important tools, what we can use them in day-to-day teaching learning practice. I can see most of the educators already here, so you can use them very handy just after the session. And finally, winding up with pros and cons. So, defining artificial intelligence. It is said that machines can think and learn. So depending on that concept, I will tell you the history very interestingly about this. If a machine starts thinking and behaves like the tasks required for human intelligence, then it is said to be artificially intelligent. So you can read the definition. It says the capability of computational systems to perform all those tasks which a human being can perform using the intelligence, like decision making, clarifying doubts, problem solving, creating images, art, etc. So anything, if a machine can do all on its own after training, that is artificial intelligence of the machine. So we were told till now that a human being can perform tasks only if he is intelligent, he or she. Now the machines are doing that, and so they are termed as intelligent artificial beings. Now a very interesting history. It all started with one basic thought by one mathematician or a computer scientist. I'm sure you've heard of him. He was Alan Turing. Alan Turing once thought that, can machines think? That basic line gave us the revolutionary era of machine intelligence. So when he asked this question, many people started researching on it. There were obviously contradictory statements, controversies which developed, but Alan Turing gave a test. In simple words, if I have to tell you about Turing test, it was when the machine and a human being were given similar questions, and a human judge was to see whether the answers from the machine and human beings are same and indistinguishable. So if the answer from a machine was same as a human, then it was considered intelligent. And after training, these answers became more and more and more similar to human answers. And that led to the advent of the era of artificial intelligence. So once this started, our father of artificial intelligence, by name McCarthy, John McCarthy, defined it, termed it, gave it a name like AI or artificial intelligence, and he gave us a language. You know what happened was, when we spoke to a computer, we earlier had Python, C++, you must have heard of these terms. These were the languages which were necessary to communicate with the computer. A computer, if you say, I picked up the milk packet from the fridge and kept it back, and I didn't check the date, this simple sentence cannot be parsed by a computer. What I mean by that is, it cannot understand and process, give you an output. And therefore, a language was required for communication other than Python, C++, which were difficult to learn, especially for people who are not from an engineering field. So McCarthy developed a language called Lisp, L-I-S-P. Lisp language, and he's known to be the father because of that. He coined the term AI, he gave us the language to communicate, and from then on we have chatbots. First chatbot was Eliza, which came in 1964, then came Alice in 1955. They were psychometric chatbots. They could express emotions also. They were very good. They actually behaved and acted like a human, a very close human friend, which led to a lot of controversies also. With the advent of so many others, there was a historical event with the IBM Watson giving us one chatbot called Deep Blue. Now this Deep Blue defeated the most intelligent chess player of the world, and that also made history. So with that, we were sure that the chatbots could behave like humans. It just went on with the daily advent inventions, etc. Now we have voice assistants on our palm top, I mean our phones, on our tabs, on our laptops, and so many others have developed. The recent most is GPT. Can anyone recollect what's the full form? GPT stands for, especially the young PGs, Generative Pre-trained Transformers. I'm sure you know ChatGPT. So ChatGPT's advent was in 2020. We have the 5th version now, that's GPT-5, which was released in 2024. And 4th November onwards, it's exclusively free for Indians only. The Indian market is the highest for use of ChatGPT and AI tools. So from 4th November till 1 year, you can all use ChatGPT for free. So this is how our evolution happened, and a lot of things in our daily life, unknowingly we are using artificial intelligence. So this is how it went on. Just a word about, I will not go into the details, of types of AI. What we are using till now is what is called as a narrow AI. This is a very weak AI and is very, very directed. I mean to say very specific to one task. Like we are using NMC app for face attendance every day, that is a narrow AI example. Automated cars, what we are using are all narrow AI. The next one is the general AI, which is considered as a strong AI, but we are still new to this and the work is still in an embryonic stage. There is something called super AI, which behaves much more intelligent than humans, but it's just a fantasy right now. We are still very far from even realizing it. Therefore, these are the types which are now in place for our use. Now this comes the point where I probably need a lot of your attention to understand what I have to tell you here. Simplifying the facts to tell you those future talks, future videos which you need to understand. If I had to know these 5 terms related to AI, what would that be? If you think of a broad umbrella-like situation or a broad area-like situation, then it is artificial intelligence. It's the broadest term for our subject today. AI stands for any machine, computational machine which can learn and produce an output, like the human intelligence is AI. A narrower part of AI is the next term called machine learning. If you give a lot of data to the machine, multiple data sets to learn, it learns on its own, creates something new, that is machine learning, a smaller part of AI. Next comes deep learning. You need a tool to dive deep into a problem. You don't know the solution for that problem. You need multiple reviews to be done of the literature and various tests that are carried out. Use deep learning. It is a neural network of multiple neurons or circuits like a human brain. So that's deep learning. Next comes generative AI. As the word itself indicates, generative AI is that kind of a software. It generates something new. Imagine something didn't exist. A PDF didn't exist, PPT, image, audio, video was not there till you created. That's generative AI. That means you have an idea in your mind, you give an instruction which is called as a prompt to the AI tool, and it will give you something very new. Not unthought of, because you or somebody else must have had that idea, but it generates an entire new item, and that is generative AI. As I was telling you that the interaction between a computer and a human is very difficult, we have a language for it, and that's called NLP, or natural language processing. So AI, ML, DL, generative AI and NLP are these important terminologies to be known before you start using a tool. I don't say that if you are ignorant and you cannot use the tool, it's not like that, but then for an effective use, because you have to command perfectly without any mistakes when you type your instruction to the machine, you need at least basic information of this. The last one stands for LLM, or large language models. So you see it here in the last inner circle. Large language models are those tools which have come as a part of generative AI. They help you make new PDFs, new PowerPoints, new Word document, just with one single line, one single thought, one single prompt. If you have that, you can make all of these. If you use a tool to generate a single specific document, image, or an audio video, it is a vertical AI. It does only one specific task. If you combine everything, make a complete cinema, a complete video, you have multiple formats in it, and that's multimodal. That's multimodal LLM. So I'm sure I have tried to make you understand. Those who visually understand or listen and understand have done that. But to give you how it can be made more effective in your classrooms, I have actually prepared a video. This video is not available anywhere on the internet. It's not downloaded from YouTube. I've just used the app to make it. The video is made from an app called Motion. So you can see the apps, wherever you find the magnifying glass, you can see that this app actually has been used to create the video. So please enjoy it.
At a new age medical college, the faculty gathered to plan how to transform medical education. The visionary dean of our story is the who says to his team, "Good morning, team. Our mission is to make learning intelligent, adaptive, and human-centered." Dr. Machine Learning is the evidence-based teacher. He says, "Dean, give me examples. 10,000 ECGs labeled normal and abnormal, and I'll teach students how to recognize patterns." The Dean AI introduces him as the machine learning who always learning from data, just like a good resident. The imaging specialist, Dr. Deep Learning, who goes deeper into all aspects, says, "I can read images and see what others miss. TB spots, brain bleeds, even cancer cells." Dean AI introduces DL as the one with bigger network of neurons. Dr. NLP, the language expert, Dean AI introduces Dr. NLP as the linguistic daughter, the one who helps machines understand our medical language, who helps us talk to the students, summarize research papers, answer drug queries, and translate lectures. Resident LLM is generative AI, the creative PG, who can generate a pharmacology quiz for next week's class. The Dean AI says, "We've made great progress, but AI won't replace medical educators. But those who use AI wisely will redefine education itself."
So if you have noticed, what concept I just told you has been made into a video and probably is more effective to transfer the information just by not saying it, but by showing it. So this video just took me 15 minutes literally to make it. I just had a thought. I had to chat with the AI. I had to give some instructions, a prompt that I say, and then it generated this. Yes, of course, the tool needs credits and can be also a premium version, but all that I've used today are free versions. So now you see this. Can anyone tell me what that is? Alexa, our smart home device. Now if I ask Alexa to smile, it will smile. I have a video also of that, but that would take time, so let me not show you that. It would just say, if I had to ask her to smile, then it would smile. Now if I had to, Now if I had to feed an image and ask them to create, the AI to create a Ghibli image, just pay attention to what it creates. Did you see the difference? Now if I had to paint it, it would take ages. Of course, I should have that talent, but then it has misidentified someone. Am I right? So can anyone tell me what this is when something with AI goes wrong? Exactly, hallucination. So you need to remember this. I just put this point to tell you that though AI seems so very impressive, it can go wrong. And it can have, Right. So just to gauge whether you understood the video, I request the PJs or whoever doesn't mind to just raise your fingers and as well as hand, of course, to make it visible, to tell me the answer to this question. The question says, which of the following subset of AI learns from a large amount of or volumes of data in multiple subsets? Which one do you think is the right answer? 1, 2, 3, or 4? Can anyone just raise your fingers and tell me? With the video, you should be able to make out. The one part. Second, anyone with a different answer? Most of you say 2. 2, okay. 3, all right. 3, okay. The right answer is machine learning. Machine learning is the one I just told you is a second subset. Oh, okay, the video didn't work then. Okay, we could have had more of information in the video. I made it short just because of the time constraints. The machine learning is a subset of AI which learns from large amount of data. LLM is a model which creates the data. Now here I come to the third point of our discussion, that is uses of AI in our profession. Day-to-day life we have so many, as I mentioned to you, virtual assistants, our planners, our entertainment, Netflix, recommendation in Google and so many other apps. All of those are for our daily ordinary life. But what more important is those in our profession, in healthcare, in medical education and research. Again the topic restricting only to medical education. You see that this image was not there before it was created by the app. So I have used something called Napkin AI to create this image. I'll show you a small demo of it also. So this image can be anything which you can add for as a prompt and create. So in healthcare, we have so many areas. You've been listening to all of this since yesterday. We have even precision surgeries can be trained, performed by an AI bot, but definitely not without an experienced surgeon. Similarly, so many other aspects of personalized medicine find place in AI in healthcare. But in our medical education, how AI has changed. Now, as I was telling you, we have moved from our traditional era of using chalk and board to chatbots now. We also have had textbooks, dissection tables, etc. We have moved to digital revolution. We made PowerPoints, which was, of course, a difficult transition for many of us. We used online resources. We used various learning management systems or LMS. We all have our own LMS in our universities. We all had interactive phase where CBME Advent brought in so many simulation lab, Minikins and so many other softwares, especially CAL software for our subject. And now we are into an era where AI is the future of teaching learning. We may lag behind if we do not have a hands-on experience with personalized tutors and AI mentoring. Now these are digital tutors. You can see there are so many apps already with the students. The students' Marrow and all that has become old now. They are all on Otter, they are all on Quiz, they are all on Ekalavya app, and these apps will give them immediate feedback. That is, they just have to have some content with them. Once fed, the apps will tell them where they are going wrong, where they are weak at, what portion needs to be revised. Even some questions and quiz and various items are proposed by the system, and the students can then and there come to know the answers. So they all are using, at least in my institute, so many of them have purchased and they are premium versions which are with them. Therefore, this is the new way of learning, teaching as well. And so the AI tools are making a mark already. This slide I have prepared from Gamma AI. That is, I have typed very little. I have typed only one sentence of making this slide, and I have a video also for that I'll show you. It has prepared on its own. This whole slide is from Gamma AI. So, if at all it is that beneficial, if AI tools are that effective, that useful for our students and faculty, then how does it make a difference? Now, the benefits are personalized learning for the students. I did tell you what happens when they use such apps. They learn by themselves, they come to know their weak points, they are tutored for their areas of grayness, etc. They also have an ability to generate their own answers. Both teachers and the students can generate new things. I told you just now that with a click you can make your PPTs, with a click you can make images, videos, etc. For content creation and modification, that is curation, you have so many tools. So you can modify, make your own resources much more beautiful and authentic than available in YouTube or any other source on the internet. So for content creation, personalized learning, research, we have these tools. Not only that, you can see on the right last, decreasing the cognitive burden. Now most of the students complain that they are overburdened with reading. They are having so many assignments, so many subjects to read. Now with this kind of tutoring, it seems the literature says that the burden on the students can be reduced because they will focus mainly on the weak areas where they do not follow, and they would not just blindly read everything. And that's how it is useful. We also have administrative assistants and also automated assessments. What it means is you just have to ask the AI to make rubrics, you can have quizzes, you can have tests, you can have notes, all that can be done by a click, and definitely the faculty can have a lesser burden. So this image also is not mine, it is generated from Napkin AI. I just put the prompt and it has given me this beautiful image. What that one was the one which I had thought I would put in the slide. I just put that in the app and I got this beautiful image. So you can use, it's free, you can generate many such images. These are the benefits of using AI in education. So similarly here, I will just go through quickly. You can see for content creation, you can make so many slides, etc. You can use AI tools for your internal assessment, formative assessment, continuous assessment, as well as your final summative. It will give you everything ready. You will get analytics of different scores of the students, where they lack, what is the poor learner, intelligent learner, etc. It also helps you in skills training. Now you can see that images have been fed to AI. It will tell you where and what the student is missing out on. You can even have virtual cases, the interactive cases with the computers you can make with use of AI. You can also have simulation. What you see at the end is a VR goggle. The VR goggles are inbuilt with AI softwares. Now these will show you in depth of a particular system. So you wear the VI, and the VI glass, the Google VI glass, will show you the depth of the pancreas, the depth of the liver, the walls of the heart, and you can even come out just by moving away. So it's that very easy and newer a technique. So these are the benefits of using AI in our day-to-day teaching learning. Lastly, I have a few videos to show you, because I thought just orally telling you these things would seem very impractical, and therefore I have cut down and I have made them into these headers. First few I am showing you for content creation, content like PPT modification, image creation, class interactions, and some games, academic games which can be played right in the class. Then there are video creations, what is called a cinema education, using cinema movies for teaching. Then there is creation of questions. Most of us are worried how to make MCQs now. It is just a click away, within seconds you have a question paper ready, as well as how to write role play scripts for our EdCom modules. I have a few for that also, and of course assessment. Now this slide also is modified by Designer. The Designer app is just a plugin in your PPT. I'm sure all of us are using PPT. You just have to download Microsoft Designer, put it in your PPT slide. When you type on the right hand side, immediately you get so many suggestions. You can modify the way you want. Just a click and the design changes. What I mean is the complete layout of the slide changes with Designer. I'm sure most of you have used it. So let me take you through some of the interactions. This is the list. Most importantly, I have to tell you, if I start naming, or if I ask you, there are numerous, thousands of apps. I have put a list here just of the ones which I have used. I'll just mark them here and I will show you a demo of all of these. What are the pros? Most of them are free. You get 20 credits, 40 credits for use. So once in a month at least, you can use them for free. All of them are free and you can definitely use them. Some are worth subscribing, a few hundreds of rupees, 200, 300, you get for a month or so. Most of them, I'll show you the videos, you will definitely, probably like at least one or two of them. These are those which are definitely very, very useful, and I've tried and tested them. But the only cons I should be warning you of is hallucination. They can have wrong information on the slides. But if you put up your sources, say you have your PPT, ask the AI to modify it, then the chances of hallucination or things going wrong are less. So that is one thing to be kept in mind, and a few ones have a very few credits. So 1 or 2 images and you're done with your free account. So these are a few I will show you for content creation, and these are a few for gamification, interaction in the class, question creation, and the EdCom. So I have these ones which are there here for your display. I'm sure you will definitely like 1 or 2 of them. So let's begin. I'll quickly, in just few minutes, show you what are the apps that you can use. If you carefully watch the videos here, I have just screen recorded them while I was using. Because of some issues with the internet, I am showing you just the videos. Now this first one, most of you are aware, I guess, is Notebook LM by Google. Now this looks like this. It has 3 parts. Now I have created this one for the conference. You can upload up to 50 resources. You can have any document, PDF, PPT, notebook, or any other Word or a text document, even images you can feed, your PowerPoint slide you can feed. Once you're done, you can summarize, ask it to summarize. It will make a summary in the center, that is in the chat section. It will make a summary. And you see on the right hand side, you see that there are so many options available. You can have an audio overview, video overview. You can have so many others options available. Now I'll show you the video there. This is the video. I'll have an audio over it. Now this is the chat. I have given an example. My own PPT has been fed there as chemotherapy of cancer. So chemotherapy of cancer, I have just put one PPT slide from my own end, and now it has started generating the source. You can see in between, it has generated the summary. Then I gave a click to make mind maps. These are interactive mind maps. You can click on any and it expands and give you the whole view of the mind map. These are downloadable. You can use them in your classrooms. You can just put any content and download your mind maps. Now I have started generating flashcards. I have just clicked flashcards and it has given me 75 flashcards in a second. The first page of the flashcard is a question. If I click there, it turns and gives me the answer to that. Now the answer is at the back end side, but I probably have not understood it, and so I ask it to explain. Within less than a second, it has given me explanation of that flashcard. So in seconds to minutes, you have summary, you have mind maps, you have flashcards, you can even make notes. Now, if you carefully listen, I am generating an audio overview.
And welcome to another deep dive. You know we love to get our hands dirty with the latest research, and today we're tackling the world of cancer and chemotherapy.
That's right.
You've sent in some fascinating excerpts from chemotherapycancer.pdf, and we're ready to dig in.
Absolutely.
So let's jump right in. First things first, what exactly is cancer? The source describes it like a stubborn crab, clinging tightly, growing uncontrollably.
I love.
So this is what it is going to do. Say you're traveling and you have a class very next morning and you don't have the facility to read it. You have this document, you can make the AI read it for you. There is an interaction between 2 chatbots, as you heard. A male and a female voice will interact and you can listen to it. They all are talking about your PPT only, that which you have fed. So there's nothing unauthentic here. What resources you have put, they have summarized and they are going to talk. In case you quickly think of a question, you can interact with the chatbots, ask a question, pause it, ask a question, it will reply immediately. So that's the beauty of Notebook LM. We even have a new option of audio and video overview. You all can try it once back to your rooms. So this is Notebook LM. The second one, and one of my favorites, a multitasking AI tool called Brisk AI for teachers. It's for students also. You should actually try this. It's free and simple. You just have to download it. You can see on the right hand side corner, the fourth or the first icon, from starting on the first icon, because I'm not able to move. Yeah, this is the one. This icon is the one which indicates that you have installed it successfully. And then you see that this is the app. The app for teachers, it can give you feedback, it can make presentations, quiz, notes, rubrics, anything that you want for your class, everything can be generated here. It can give you detailed documents as per your instruction. Now this is how the interface looks. A right to lower anchor, like image comes to you, you have to click that and you get this prompt box or a window. There you type some of your contents, like for example, you set a quiz, you want it for the university, you set the standard, and then you also make all of these. You can make even a lesson plan, curricular changes, etc., and you can create it. Now to show you an example, I am creating 5 MCQ questions with the topic of anti-cancer drugs again, and setting the grade as university. I want the output of 5 MCQs in directly a Google form. I don't want a Word document, then type it in the Google form. I don't want to do all of that. So I have set the output mode as a Google form. So you can see I am typing the prompt there. As specific as possible, makes hallucination less, makes your work easy. So I have typed that create 5 MCQs with moderate difficulty for MBBS phase 2 students in the pharmacological classification of anti-cancer drugs. So if I have done that and I have fixed all these 5 MCQ sets and I have made the option for downloading and the Google form. So as I create it, I have to log in. If I have not logged in, probably I'm not able to use it. So what I do is I log in with my account, and once I'm done, you see in seconds, it will give me a 5 MCQ related question paper. So you see it has already started typing, it is generating a Google form in seconds. So after you have logged in, it just takes less than a minute to make a downloadable Google form with 5 MCQs. So it has generated and also will give you references from where you have generated. That means if you have references ready, you can upload it directly from the reference only it will make. But if you don't have references uploaded, it will give you the references. So you see this is an easily downloadable also. You can import this Google form or can share it with your students directly. So that was Brisk AI. This is the tool which probably is most, I don't know what to say, abused or misused. I would suggest on this platform that we shouldn't download a directly prepared PPT. But in emergencies, all of us know it's so difficult. At times we forget the classes. So at that time, this is the most handy tool. Gamma AI. Now you see how it generates. I just generated a PPT in less than a minute. I have given a prompt of making a presentation in a traditional style of 16:9, 5 slides on classification of anti-cancer drugs. So I write a prompt and there it goes in English with pictures. I can make this prompt even more specific, very, very clear, very, very nice to know, and whatever you want, you can add there and modify it also later. Believe me, if we have SlideShare or any other app which gives us those, they are unmodifiable. Either they are PDF files or those which cannot be modified. But here you get a completely modifiable, customizable PPT. So that's how it is, and you see that once I have completed this task of my prompt session, it starts creating. But before it creates slides, it will give you an outline, whether you are okay with the content or no. You can modify this outline also. See, it has given me a 5-slide content with the headers and subsequent bullet points. But if I'm not okay, I can actually change it, or I can even add content to it. But if I'm okay and I say generate, it will generate slides. See, the time, you can even time it because it was live when I did it. When I screen recorded it, it just took me 3 minutes to make the whole thing. So you see it is already generating. You can see what all images have been added. The only problem that happened or I did was, I did not give it a clear prompt. I should have said 6x6 rule, or I should have said that less than 6 or 7 lines per slide, add less content, don't make sentences, keep less image, space for image and more for the text. Something like that if I had added, I would have get a more refined PPT. So you see the content is so very high in this, you can modify it. But my idea was to demonstrate that these apps are so very clickable, so very usable. So you can do this, and this is ready. This app gives me a PowerPoint presentation on classification of anti-cancer drugs with a few of those mechanisms ready. I can even change the prompt. Now you see it is downloadable and in the format of PPT only. So it downloads and you can save and modify it. So I hope you find this useful and you can try it out, but my suggestion again remains, don't generate PPTs by the AI. If you have, you can modify them. You can upload your PPT and modify it. So this is the Gamma AI. The next one, which is very impressive only for image generation, sorry, is Napkin AI. Sorry. So this is a blank napkin. You go into Napkin AI, Google, and type it and open it. Now I have just typed one phrase classification of anti-cancer drugs. I write the same and I get an icon to make an image. So it's that simple. Even children, even in school, can make this. So I have typed anti-cancer drug classification. So once I do that and I flash it, I see an image of multiple types that has been given to me. I get many options to create different type of images. So here it is. I have got the icon, and you see the flash icon comes over there and it has started moving. The pixel movement shows that it is creating. Now you see it has, for one phrase of anti-cancer drugs, it has given me so many options of different images. Believe me, they were not there before it was created. They were not there in, you can try in Google Images or any PowerPoints, we don't have them. The images may look similar, content will be different. So among all of these, I can choose one image and I can fix it and I can even modify the image. So you see, I'll just move it ahead. So this is the one which I selected, and then you see on the top right icon, I have edited the image and I can download it, zoom, add, edit, and then add to my PowerPoint. So this is Napkin AI for image generation. Now this is a small video I have prepared for EdCom. Now most of us are having, I'm sure with 2024 guidelines, 3 EdCom modules. I chose one. The script of the video is from the EdCom NMC document. I just put this script in ChatGPT. I have used 3 tools for information. ChatGPT to make my script, role play script and dialogues. So once that also took me maybe 1 or 2 minutes. Once I made the script, I have used this script in another tool called TTS Maker. Now this TTS Maker will give me an audio file. It will read whatever script I have given and it will make an audio MP3 file. So I generated the script with ChatGPT. An audio file, which you will hear now, is from TTS Maker. To fuse the two and make a movie, I have used Clidio or Clidio. Now, videos are clubbed, audios are clubbed with this. ChatGPT for role play and photographs, and the whole audio overview or dialogues is with TTS Maker. So this is the less than 2-minute wala EdCom for our subject.
Mrs. Lakshmi Srinivasan, a 48-year-old woman presenting with lymphadenopathy and complaining of mild fever and weight loss for the past 4 to 5 months. On examination, there are large rubbery lymph nodes in the axilla and groin and a palpable spleen. She is accompanied by her caring husband, Mr. Srinivasan. Lakshmi undergoes lymph node biopsy and the pathologist calls Dr. Mehta and tells that Lakshmi has a lymphoma. That evening MR, Srinivasan comes into the office of Dr. Mehta and leaves the report on his table, in which the final diagnosis has been altered to tuberculosis by whitening out the pathologist's report. When Dr. Mehta looks up, Mr. Srinivasan says, "My wife can't handle that diagnosis. She has always been a worried, frightened person. Please tell my wife that she has tuberculosis." Dr. Mehta says to Mrs. Lakshmi, "Your biopsy report shows a condition called lymphoma. The good news is that it is treatable." Lakshmi says worriedly, "Lymphoma? Is that cancer, doctor?" Dr. Mehta says, "Yes, it is a kind of cancer, but with modern therapy, many people recover well. I'll be with you throughout the treatment." Mr. Srinivasan then regretfully says, "Doctor, I just wanted to protect her." Dr. Mehta kindly says, "I know. But truth, told with compassion, helps patients make their own choices. It is her right to know about her diagnosis."
So if you can see in the video, I have just typed the same thing that our EdCom booklet has given. If you have gone through it, EdCom 2.5 of NMC document gives this text only. So you see there are no videos as of now on any platform, and this is freshly created by AI. But I have I have used these platforms. So here is the ChatGPT window where I have created that, I have pasted that paragraph. It has given me scene-wise. There are 6 scenes in the whole movie. It has divided it into 6 scenes and given the dialogues dialogues, and those dialogues only I have used to make the audio file. It has also given me the photographs for the video. I just have to keep reforming them because I told you hallucination. It sometimes changed the husband to the doctor, doctor to the husband, or the patient wearing a different colored outfit and all that. So when you are giving prompts to ChatGPT for especially an image creation, you have to be a little more careful, observant. Even the background, what you saw, the board of ethics to be followed, or tuberculosis can be prevented, all that you can actually tell the AI chatbot to make. So this took a very long time for me to make these pictures, 6 or 7 pictures, and the scenes to be written. So once done, I pasted this in TTS Maker to get the audio file, merged them in Clidio, all on free. I have not used any premium account here, everything was free. Then the second is Motion app. You saw that video, the digital video at the beginning to show you those 5 relation between AI, ML, deep learning, etc. That was the interface. That means it gives you n number of options. You can make a comic strip, you can make a colorful, authentic, real life image, etc. So I'm sure most of us have used that. That is the Motion app. So finally, this is one last app. Maybe 2 more I have, but I'll quickly tell you how to use games in your classroom. For this, I have used one of our practical competencies, interaction of a medical representative with the doctor. After the session on practicals, after the discussion, I actually had used this game in the class to gauge the students' knowledge on it. I'll just fast forward and show you that. So this is the game. I have fed in questions which I framed on the practical, and the students will jump from one question to another. Sorry, it was too much of a forward, I guess. So you see that the students can opt for these answers and they keep clicking. If one wrong answer, they lose a life. So within 3 lives or a fixed time, they have to keep answering to reach there. So those 5 questions which were prepared were after the practical session. So it looked something like this. This is the interface of Educa Play, wherein you type in questions and it generates a game. You can make a puzzle, you can make a froggy jump, you can make a word, you can make identifying the gaps, and so many. There are so many games. You can just type Educa Play and you can explore more. There are a lot many. I had that, but it would be a very long video. So that's Educa Play. A similar one is Amuse Labs. You can actually play these games, and my feedback in the past 4-5 years has been incredible. The students actually love playing such games in the class after the session, of course. The last app, the most useful app, Question Well. Most of us are setting MCQs. I don't claim that this app makes absolutely perfect MCQs, but it is definitely a very good one for a beginner or for us to begin with. Even experienced people can just start using it. Now this is the interface. You can see that the Question Well page is open. I have given a prompt of creating 5 multiple choice questions on anti-cancer drugs at the graduate level based on some textbook or a PPT that I have uploaded. This speciality of this app is, in most of the universities now, they're asking for Bloom's taxonomy. I don't know whether it is there with RGHS, but then Bloom's taxonomy is one which grades the different levels of learning. So that also is followed in this app. So it will generate, see, within a second or 2, it has given me 5 MCQs of anti-cancer drugs with answers, with references, and that is customizable. You can modify and make your own. This is also downloadable. You can download. You can even give directly to the university with the various Bloom's taxonomical levels. And this one can be used even for internal assessment as well as for your final exams. Now you would ask me that if it is generated like this and it is kept on the internet, will the student not get an access to it, or someone else can leak the question paper? No, it is only with you. It's a password protected file. So unless you share your password, it won't be. And once created, you can save it with you and delete it from the platform. That's also a quite safe thing to do. So this is how you get the question paper in Question Well. There are so many, but this is one which I have tried and found to be very useful. So finally, to wind up, nothing comes free, as madam was saying. Nothing should be actually free, loses its value. So here also, there are a lot of challenges, especially ethical and otherwise. Data privacy, because we are identifying students on that platform with their personal data. It could be expensive. It needs a lot of technical support from an IT team if at all the teachers or the students are not tech savvy. Over reliance, we may tend to forget making our scripts or PPTs after complete using, so we shouldn't get addicted to them. Academic integrity, plagiarism is a question, so definitely if you are trying to publish something with this, you will have to copyright them or take permission, and also make clear policies at the institutional level as to where you will stop using AI or for what is it allowed. So these are some challenges, pros and cons of the use of AI. I have made it with that napkin app. So I wind up by saying an intelligent integration. Please mind my words. An intelligent and most importantly, proactive integration of AI tools with the help of the institution and the IT team is the future of our education. Because if we are ignorant, if we don't want to change, then it's going to be really difficult. The people of future will definitely need this for their development. So we will have to definitely use this. I'm sure most of you have seen the column of Life Out of Control from Times of India, published almost daily by Sandeep. Now he says that earlier we believed automation would reduce the burden. But now what are we doing? It has doubled the burden. We are both doing it digitally as well as on paper. We are already having hard copies and soft copies. So we are doubling the work. So when we talk about AI, this should not repeat. We should not be doing it both the ways, by AI and manually. So a perfect integration of the two. That means where you will use AI and where you will not use AI should be clear cut with us, especially the faculty. And we should be proactive in learning. By the time I presented today, so many other new things might have already come and I am ignorant about it. And so that should not happen with the faculty, especially because we are medical educators, we are educating our future generation. So I would request, this was not working. Anyways, this is another tool called Slido. This would have actually allowed you to give me answers directly now, but is not working. I'm sure most of you have used it, so let me skip. There would have been a scan code here, which if at all you scanned it for a classroom of 100 students, it would have been free. You would have been able to rank my options, but now it is not, we are not able to install it on the computer. So sadly, I will not be able to use it. It also has a quiz actually. So this quiz would have told us who is a winner among you. But then sadly this is not working, but please try it on your PCs in your class. This is beautiful, an app called Slido. So these are the references. I will come back to the references once I have a request. Now most of us feel that AI might replace medical educators. This is a debatable topic. Some of us feel it would, some of us feel it wouldn't. But if you ask me my take, I believe what George Course said. He says that technology will never replace great teachers, but technology in the hands of great teachers can be transformational. So this is what I believe. If we use this technology judiciously, nothing like it. It is a very beautiful, easy to make life tool. So you can definitely integrate, use it judiciously, as well as share it with your friends and colleagues to make our life easy. So just before I show you the references, I request all of you to please give me your honest feedback. You can scan the code with your camera app. If you use internet, it would only then work. With the camera app or your Google Lens, you can just scan and give me your feedback. Till people are giving us feedback, ma'am, if chairpersons permit, we can have some questions, if at all we have time. I can share the link with the organizing team also for the sharing of the feedback, as well as at the end of the Google form, there are apps which I showed you. The apps which I have actually used, you will find all the list of those apps in the feedback form. Your internet has to be on to be able to answer the feedback.
No, excuse me, ma'am.
Yes.
Here. Thank you, Dr. Radhika.
Thank you.
You have delivered a talk of AI. Because of the time constraint, you had to jump through a few slides. I have two questions for you.
Yes.
We are all healthcare professionals, and we talk about empathy, sympathy. How do you think AI will help us really?
Ma'am, absolute form, but not empathetically. That is what has been the major problem. Though they tried psychometric measures to be incorporated in a robot, but then they can say, I am so worried, but it has no empathy or any kind of feeling behind it. They are completely empathy-less. So that is one major problem, and super AI that I showed you just now may address that, but that is a far from reality thing right now. So empathetically, we cannot expect robots to perform.
The other question for you is, what is the long-term impact of AI on thinking ability of us?
I totally agree with you. Probably I just made a mark also on that we may become over-reliant on AI. We may actually stop, like we have already seen with the use of mobile phones. We are doing so many tasks mindlessly. For example, so many tasks which we had to get up from our place and do, we have reduced doing that. With smartphones, smart devices, and so many other things, similar thing we may expect in future, that we may become over-reliant. As I said, we may even forget how to even make our own PPTs at a point of time. But hopefully that we are mindful of this and we remember that that is not the way to go about.
Thank you, Radhika.
Thank
Two
you.
questions permitted from the audience due to lack of time.
Okay. Good morning, ma'am. Here.
Good morning, sir.
Ma'am, this is a nice quote, but like what about ordinary teachers? Means not everyone can be great teachers, and ordinary teachers, they have also like spouse and all to look after. If their jobs get replaced, what they should do?
Sir, as I was telling you, no AI will replace you. No AI will replace anybody, be it a teacher or otherwise any profession. AI is human generated. So I still believe that AI will not replace, or technology will not replace teachers, ordinary or extraordinary. It cannot replace anyone, but it can make you ordinary or extraordinary. If anyone who is not ignorant, who well versed with the technology or tries to use technology to the extent possible, I don't say you have to do only this, anything that's possible, and to not run a rat race, but to make your own presentations less boring, more interesting, more innovative, interactive, you will be an extraordinary presenter. Not you, I mean the person using it. So definitely it will not replace anyone. That's my belief. There are controversial, debatable points, but yes, I still feel it is not going to replace. It's just about how we use it. Use it in a proper way. Thank you, ma'am.
What I appreciate is most of them are usable.
Yes, ma'am.
It's not something not reachable to us. Yeah. My question was, now using these AI tools to generate questions, what if our students use the same tool to generate questions? Will it generate in the same way? Or
Ma'am, very nice point. It all depends on your prompt. So every individual, when typing in Google also, we are different. It does give suggestions, but then you will probably not do the same. So the students will not be that good at making a question. So when they use a prompt, they would be a student prompt. It would be very basic, or maybe sometimes, sorry to say, lame. So they may not be able to generate the questions of your kind. A teacher who is having so many years of experience, if you frame your prompts very specifically, try them and you see your questions. If you see they are very, very basic, very, very similar, you change. So it is not that once you generate a question, it is not changeable or modifiable. Your prompt decides everything. So, but if you share how you prepare a prompt with your students, yes, they would be able to do
now
it.
if it is a broader prompt, like, you just named a chapter name.
Yes.
And just generate 10 MCQs.
Yes.
Will it be same?
No, it will still be different for you and for any other user. It will be different. If you want to make it still more specific only to you, then you can feed in your source. Say if you again feed a textbook, it might be similar, but not the same again. You can try among your own small group of trustable people. You will see all of you, when putting the same prompt, even with the same source, you will get different MCQs, different questions for that matter. So it will be different.
Thank you, Dr. Radhika.
Thank you.
Others, if you have any questions, maybe during the break time you can do, because we cannot go overboard, and there is a next session as well.
Yes, ma'am.
Thank you, Radhika.
Thank you, ma'am. Thank you so much. Thank you, ma'am.
Thank you so much, Dr. Radhika Sherkhane, for your perspective on how AI can revolutionize medical learning. Truly inspires us to adapt and evolve in this digital era. Now I request the chairpersons to hand over the token of gratitude to Dr. Radhika Sherkhane. Dr. Sarala N.
At Subbaiah Medical College, it's my pleasure to be your host for today's conference. Moving on to our next session, one that will surely interest all budding pharmacologists. We are honored to have with us Dr. Akash Dhruva, currently serving as the Global Clinical Strategy Lead at Viatris, to deliver the talk on the topic Career Opportunities. Where can pharmacology take me? We welcome you on the dais, sir. Now I welcome chairpersons for this session, Dr. Satyanarayana V. and Manu sir, to the dais. Dr. Manuji is currently working as Associate Professor of Pharmacology, JSS Medical College, Mysore. Dr. Satyanarayana V. is currently working as Professor and HOD of Pharmacology, Bangalore. We are privileged to have both of you with us today to chair this session. I request the chairperson to introduce the speaker, Dr. Akash Dhruva.
MBBS at Vijayanagara Institute of Medical Sciences and MD in Pharmacology at CMC Vellore. His remarkable journey includes serving as medical advisor at Boehringer Ingelheim and AstraZeneca. He was a winner of the prestigious Biocamp 2019 Leadership Program by Novartis and recipient of the Best Paper and UK Seth Prize at 51st IPSCON 2019 Hyderabad. Dr. Akash has presented at international platforms, co-authored clinical trials and consensus documents, and led global clinical teams for major drug acquisitions worth billions. Beyond his professional excellence, he is also a passionate poet and photographer. Over to you.
Yeah, thank you. Thank you, everyone. At the outset, I would like to thank the organizers. So, the topic career opportunities after MD pharmacology. Just a disclaimer that I'm a pharmacologist, as we all are. To just save time, let's just assume we are all right and proceed. Is this working? Yeah. So, when I was given, the topic to speak on the career opportunities, I just thought how well can I prepare, or what topics can I present which can encompass all the options that are available for an MD pharmacologist. So at the outset, I would really like to say that the academia opportunity is immense, and you have got great advisors, great mentors from your institution in this place as well, and at multiple conferences who will guide you better in that aspect. But for me, when I was thinking of career opportunities, I thought it shouldn't be something as simple as, I can Google something as career opportunities after MD pharmacology or YouTube and you get the options. I just wanted to say that MD pharmacology intersects at every phase of a medicine's life cycle. And that is from the stage where the drug is in the market to the bench where the drug is discovered. And this is not a boast, but MD pharmacology intersects from phase 0 to the phase 4 where the drug is there. Is there anybody who can identify the drug which is there on the right-hand side of the projector? We just had that talk by Dr. Praveen sir in the morning. Yes, sir. That's the famous anti-obesity drug, semaglutide. So semaglutide by itself, we all know it's a GLP-1 agonist. GLP-1 is something which is produced within our body, but DPP-4 degrades it immediately. So it is just a simple drug which has revolutionized medicine just because of the three things that you can see there. The two which are highlighted in green, the AIB and R, and the chain of acids which are present at the bottom. So that work is done by a pharmacologist. So what you can see is that replacement of AIB there led to the development of semaglutide, which was a long-acting GLP-1, which would prevent the inhibition of prevent the degradation by DPP-4, and the R, which is basically where there is a substitution of an amino acid, which led to its stronger half-life. And that acid is to just make sure that the drug binds to the correct site. So this drug, which is a simple peptide of 35 plus amino acids, is a multi-billion-dollar product, raking in more than 10 billion. So what makes it a blockbuster product is something that is not the scope of this discussion. The scope of the discussion is, now the drug is in the market, so where all did a MD pharmacologist play a role right from its conception, but in the reverse way? So this is just a brief history of how semaglutide got its approval. It started off with type 2 diabetes, and then during their clinical trials, they observed, they meaning MD pharmacologists or people with pharmacology background, observed that there was a benefit in the cardiovascular risks and the weight reduction. So then they decided that this could be a scope for an obesity, that this could be developed as a drug for obesity. And then they did an injectable semaglutide, which we know as Wegovy, and then they're developing an oral semaglutide, which is currently approved for type 2 diabetes, which will end up getting approved for weight loss as well in the near future. So from the store to the textbook. So what we have in the stores as semaglutide or Wegovy or Ribelsis, and it is there in printed in on all the textbooks in the relevant chapters, and which you all seek help from in the end. And as I told, the academia of the MD pharmacology is itself a huge universe, and your mentors, your guides are better equipped to advise you on that front with the DM and the other after post-graduation opportunities. So when the drug is already a product, what can an MD pharmacology do? So the drug is already in the market, semaglutide is being marketed. But if you see, there was a recent review by European Regulatory Agency, which told that the use of semaglutide medicines led to an increased risk of an eye condition called as non-arteritic anterior ischemic optic neuropathy. And this was possible because of something within the scope of the pharmaceutical industry called as a drug safety physician, which belongs to the pharmacovigilance department. So they ensure that there is a long-term safety risk profile of the drug by continuously monitoring the side effects, the adverse effects, which are being reported to them. And then they saw that this Na ion was in increased prevalence with drugs, with people who are using semaglutide. So there is a scope of a drug safety physician where you can end up monitoring the drug for a period of time and which can impact patients' lives, such as identification of this adverse risk. And also there is something called as real-world evidence lead. Real-world evidence is something when the drug is already in the market and you want to find out if there is any other use of the drug other than what it is intended for. Now we know semaglutide was approved for type 2 diabetes in the beginning, and then they realized through patient registries, through health records, that the benefit of weight reduction is not just observed in clinical trials, but also in real world when the patients were taking drugs. And so this real world evidence helped in the cost effectiveness, the cost evaluation of the drug. And that's where a real world evidence, which is led again by an MD pharmacologist, if the drug is already in the market and you believe that there is other use for the drug other than what it is intended for. And when the drug is about to be a product, so this is a whole new world where most of the MD pharmacologists who want to go into the industry end up in medical affairs. Some might call it a glorified marketing job because you end up meeting doctors and suggesting to them the scientific benefits of the drug. But again, it's a very key factor because without usage of the drug, there is no drug itself. And without the drug, there are no patients who are getting benefited. So the universe of medical affairs is primarily involves scientific platform development. Here you'll have to position, say for this purpose of this talk, semaglutide, what is the GLP-1 receptor biology? How does GLP-1 receptor actually help in weight reduction mechanism? Then you go to the core message. What is it that exactly helps semaglutide differentiate from the other previous generation of weight anti-obesity drugs which came into the picture? And what are the relevance of their key endpoints? So why was a cardiovascular risk MACE reduction was taken as an endpoint? Why was BMI reduction less than 35% taken as an endpoint? So all these are the core messaging which are obtained from the clinical trials. And that helps in guiding why they are necessary and why are these endpoints chosen for that particular drug. And then the medical affairs also involves in evidence generation strategy. So you finalize the phase 3 strategic publications, manuscripts, which are being presented in conferences by endocrinologists, by cardiologists, and then you define real world evidence priorities. So just because a drug works in clinical trial does not mean it automatically becomes a drug that is used by patients. There has to be a lot of other factors which take into consideration. Now, Dr. Praveen sir talked about CagriSema, which was a combination of cagrelitide and semaglutide, which is being developed. So what was the reason that Novo Nordisk went ahead with doing such a, the addition of another drug to its already successful semaglutide? Because semaglutide is an injectable which has to be taken every time. And here you have got an opportunity to take two drugs, which is potentially going to be taken once a month. So once the drug goes into the market and the patient says, I would prefer a drug which I can take once a month rather than an injection once a week. So those are real world evidence priorities that can help in patients taking the drugs. And then there's also KOL and expert management, which is basically you reach out to different doctors across the different therapy areas. You combine them together in an advisory board, get their inputs. You help in guideline development and speaker programs, which will help in the drug getting incorporated at various places. And then there is something called as field medical, where you go to the doctors, where the MD pharmacologists help in getting insights, where the drug is actually better, where the drug is actually not faring better, what can be done to get a better response from the patients. And then there's also collaboration with the cross-functional team. As I said before, without the sale of a drug, without sales, there is no R&D. So that's what this part is. And then there's also a continuous mode of external scientific and internal medical education, where there is white papers, partnerships with NGOs, partnerships with CMEs. You do competitive intelligence. We talked about how semaglutide's nearest competitor is tirzepatide. So Novo Nordisk's share, which was once the GDP of Denmark, collapsed drastically due to the introduction of tirzepatide. In fact, so drastic that CEOs had to resign just so that they couldn't compete with what ended up with tirzepatide. So the thing with pharma, especially in this scale, is that there is no constant. There's always a new innovation which will always push the boundaries even further. And when the drug wants to be a product, so you have the drug, everything is, so semaglutide is in the market, semaglutide, real world evidence has been generated. But what did semaglutide go through when it had to get an approval? So the whole point here where the medical MD pharmacologist can play a role as a regulatory physician or a product and a label lead. So there are courses, but primarily based out of US, such as Northeastern University, which give a course and which have courses in regulatory affairs, master courses in regulatory affairs, where you can end up being a regulatory physician. So you're involved in clinical trial application, submission of those applications to the FDA. You are involved in marketing authorization application, which is for the Europe. And then you're involved. So when you have a drug and you have a label inside the drug, which is a small sheet of paper, that goes through multiple versions of revisions and review. So that piece of paper which has the dosage, the indication, the administration, has to undergo nearly 5 to 10 times of revisions before it gets approved by the authority. So there has to be no misleading claims. There have been plenty of companies which have done misleading claims and ended up paying billions in lawsuits. So misleading claims, before it gets commercialized, the advertising language has to be very clear. What the drug is intended for and what the drug has studied in its clinical trials. And then there might be cases where the product has to be reclassified. Some of the drugs get approved for semaglutide, for example, got its approval for type 2 diabetes mellitus. But then it got a change in the language because it got approved for anti-obesity, as an anti-obesity drug. And there might be a scenario in the future of a drug where it has to go a product withdrawal. Either maybe because there is a risk of adverse events which was not studied or which was not observed in clinical trials. And even then, a regulatory physician, which an MD pharmacologist is involved in all of this. So the scope is not just where the drug is there. So there are courses which help in getting the approval of the drug as well. And when the drug is still a drug, there is no product. Semaglutide is not a Ribelsis. Semaglutide is not Wegovy. Semaglutide is just semaglutide. So where do you get semaglutide's data from? And we know the classical journey of phase 1, phase 2, phase 3, the approval, the whole pathway. But here in phase 3, as we saw, so semaglutide had multiple clinical trials. Step 1, step 2, step 3, step 4. So it is not just one study which helps in gaining its approval. And especially when the drug is something which is treating a global pandemic, like an obesity, then the multiple trials which are required in multiple subgroup of population. For example, step 1 was done in patients without type 2 diabetes, but who are obese. Step 2 was the trial which was done in both obese and type 2 diabetes. Step 3 was obese patients who were taking insulin-based therapies. So there are multiple populations which in real world would exist. The real world is not just divided into type 2 without obesity and type 2 with obesity. So every scenario, every possible scenario in a realistic scale was studied in different trials. And this is not just a company doing a trial and getting through it. This is mandated by the regulatory agencies. So here, the choosing of this indication, the choosing of the target population, the obese population, the obese with type 2 diabetes population, that is where a medical lead, a clinical development lead, which is an MD pharmacologist, plays a role. So you're involved in the protocol development right from choosing the target population to the inclusion criteria of the study. And this is where the MD pharmacologists are plenty in where you get opportunities. You're involved right from the study initiation till the study end, which includes the study conduct as well. You're involved at every stage a patient is enrolled. You monitor the safety signals. You monitor whether the subject is coming to the clinical site. So everywhere, this is where the phase 3 journey starts. And there are multiple positions, multiple names. They're called as clinical research associate, clinical research director. And you end up at the head, or as the head of clinical development for a program. So this is where the drug is finally ready to be marketed. But what was it before a drug? How did semaglutide end up proving, like, I am a drug too? So semaglutide had to prove that there had to be some benefit to it. So there are multiple phase 1 and phase 2 studies. Here you have dose ranging studies. So how did the dose of semaglutide get finalized? We saw there are multiple doses ranging from 1 milligram to nearly 30 milligrams, 40, 50 milligrams. And those are the dose ranging studies where you are involved, where you're involved in choosing the doses, where you're involved in again writing of the protocol, involved in writing with study conduct, involved in finally the results as well. And then there is safety and tolerability. So the drug has to prove it is safe. And here again you monitor the safety during the conduct of a study. And there are single dose ascending studies and multiple dose ascending studies. And these are called as, these type of positions are primarily phase 1 physician leads. You are responsible for the PK of the drug. We are involved in interpreting the pharmacokinetics of a drug to the other parts of it. Then you have renal studies, you have biomarker studies. There are plenty of phase 1-2 studies which are actually relevant for a drug to prove that it is beneficial. For example, effect of food. if semaglutide was, would get degraded after consumption of food, then there was no drug at all, because it had to maintain its effect even after food. So there is effect of food and hunger and fed state studies. So all of this encompasses before the drug gets into the phase 3. And before semaglutide, when the drug is it still a drug? So this is where you have your animal models, where there are models of animals, for example, the apolipoprotein E mice, which has got a high risk of atherosclerosis, or LDL-rich mice. So all these are fed Western diet, and then the drug is administered, and you see that the weight loss or the changes are happening in the atherosclerotic lesions, changes happening to the weight of the mice. But here again, that is done by a separate group of scientists. But what has to be done to the drug to take it to the human stage? And that's where a safety pharmacology scientist or a translational pharmacology scientist, this is again an MD with multiple layers of experience, primarily with a PhD, would help in extrapolation of this dose to humans. And that adjustment of doses has to happen in special population. So that's where again you're involved. How much of the dose can be given in renal failure patients? How much of the dose can be given in kidney failure patients? Is it contraindicated in pregnancy? Can lactating women give it? So this is where the main study is formed in this phase 1 study. And when you finally have a drug, so here are different drugs where you can see the GLP-1 analogs which are already there. But this obviously requires the next step of an MD, which would require PhD because you'll have to go through the molecule. But again, these drugs, because we're talking for the stage of semaglutide and its analogs, they're all drugs which were derived, I wouldn't say invented, derived from the minds of MD pharmacology or people with pharmacology background. Because only when you can see the chemistry can you understand what it does to the body. And GLP-1, we know it has its effect on its brain, it has its effects on the GI tract, it has its effect on the pancreas. The whole thing is just that 30 amino acid chain, 35 plus amino acid chain, which slight tweaks does to our body. And that slight 3 to 4 tweaks end up getting 5 to 10 billions in the end. And here you have got research pharmacology background, you've got computational pharmacologists, you've got DMPK scientists who help in getting these identification of these drugs from the scratch to the product. So this is a skill matrix which is there for core competencies for career acceleration. So clinical trial protocol development, medical monitoring, and PK/PD integration. Then you have medical, which is real world evidence generation, physician education, and where communication skills help. Then you've got regulatory, where you're involved in dossier preparation, you're involved in product labeling, you're involved in medical writing. And translational is where we talked about how the screening of the products is done, where you end up with multiple molecules and finally understand the receptor pharmacology, the GLP-1 receptors, the GLP-1 analogs, where do they fit? And that is the exposure response modeling. And that's where your path could be headed if you're involved in translational medicine. And in the future, as ma'am spoke about AI and machine learning and digital health and wearables, it's already here. Apple's Apple Watch is the heart monitoring technology has got an FDA approval for detection of atrial fibrillation. So digital health and wearables, specifically drug storage through a ring, which you can take the tablets or the drug is administered through the ring through form of micro needles, that's already in development. So it's an ever evolving field where AI and machine learning does play a role. But again, caution is the word here, because not everything that AI does can substitute what a man can do. It's just a tool to help you in doing better things. And the shape of clinical pharmacology is changing, especially with different modeling techniques, with different real world data which is being generated. That's no more going to be, in the near future, there will no more be a clinical trial setup where patients come and you have them monitored throughout, it's just a glorified lab rat scenario. You end up patients being in their own homes through their own devices, being the subjects for clinical trials. And there have been studies where drugs have been approved based through these decentralized trials. So, in conclusion, what I would like to say is from the conception of a molecule to the medicine, where the drug is already in the market. So, we are involved. So, from discovery stage, where the target finding and drug design is done by an MD pharmacologist with a PhD background, to the preclinical studies, where you are responsible for selection of the dose from phase 0 to phase 4. And from phase 0 studies, phase 1 studies, phase 2 studies, where you're involved right from the beginning to the end, and you're involved right in the go, no-go decision, whether the drug has to proceed to the next stage. That's where you're involved. And even in phase 4, once the drug is in the market, you can help in identifying safety signals. And most importantly, the important step, being a teacher and guiding the students once the drug is in the market and helping them understand what the drug actually does. So from that stage of an initiation to it being involved in the textbooks, the pharmacologists lead the way. And with all the uncertainty and just with AI and other courses and being there considering MD pharmacology, what is the scope of it? And what Steve Jobs used to say is like, the only way to do great work is to love what you do. So it doesn't matter what you want to do, it's just that you want to do it. It doesn't matter whether that job is something that is, what people demand or what people expect. Just do what you do. And if anybody can get the second quote, it's from a movie called Terminator. So it says the future is not set. There is no fate but what we make. So each step is by you, and this is relevant because the movie Terminator, if you think in terms of commercial potential, it made billions of dollars, got great reviews, but at one point it was about to be scrapped because they told there was no audience for the movie. And now we have got $1 billion product. So each of us, there is no future, you just have to make what we get. With that, I conclude my talk. If there's any questions, I'll be happy to take it.
Yeah. And he has told the role model of clinical pharmacologist, right from vigilance. See, still we do not know the long-term side effects of semaglutide. And even if it is there in the market, still we know the cost utilization. We do not know the benefit of this one. So a lot of cost utilization study can be done as a clinical pharmacologist and as a basic scientist in animal model, translational scientist role. And the clinical trials, I need not tell, a lot of designations are there in there,
yes, sir.
Isn't it? So there is a big gap. And in computational chemistry.
Yes. Yes, sir.
So I think PGs, it's a wonderful topic. Now questions, any questions for this session? Postgraduate students, if there are no questions, I think we'll end up this session. Okay, thank you.
Thank you.
Thank you, Dhruva.
Thank you.
Thank you, Doctor. Now I request the chairpersons to hand over the token of gratitude to Dr. Akash Dhruva. Okay, now we'll break for tea.
Invite Dr. Sidlingappa CM to hand over the prizes for the first category. So we split the paper presentation separately for staff and PGs. So the second place in paper presentation for staff goes to Dr. Industri from Siddhganga Medical College. Okay, if the participant is not there, I request anyone from the college to collect on her behalf. And the first place among staff goes to Dr. Y. Vishwanath, Ballari Medical College. The next category is paper presentation for PGs. The second place goes to Dr. Mugdha from KSMPCON Medical College. I request Dr. Mahesh GK to hand over the prizes and certificates. And the first place goes to Dr. Vishali from Hassan Institute of Medical Sciences. Thank you, sir. Now I request Dr. Abhishek Acharya to hand over the prizes for poster presentation. The second place goes to Dr. Divya T from Mandya Institute of Medical Sciences. I request everyone to clap for the winners. And the first place goes to Dr. Nikhil from ESI Medical College, Bangalore. Congratulations to all the winners. Thank you.
Engaging parts of a conference, the pharmacology quiz. The session will be conducted by two eminent academicians, Dr. Lohit K., Professor and HOD of Pharmacology, and Vice Dean, Research and Compliance, SSIMS and RCTB Gur. He has 16 years of teaching experience and he is a meritorious awardee from the Honorable Dr. APJ Abdul Kalam for being a part of National Level Quiz Runner-Up. Dr. Rajesh B., Professor and HOD, Department of Pharmacology, Sridevi Institute of Medical Sciences, Tumakuru. Dr. Rajesh brings over 17 years of teaching experience. He leads the Pharmacovigilance Subcommittee of IMA Karnataka and serves as an external PhD expert. His academic excellence is reflected through 15 research publications and recognitions such as the Muller Quest Lecture Contest Prize and the Sridevi Best Teacher Award 2025. He has been a quiz master in various CME and conferences. We now hand over the session to Dr. Lohit K. and Dr. Rajesh B. to conduct the quiz.
Flooded since morning, like we are seeing many delegates coming to the session. And before starting this session, I want to thank Hassan Institute, Sidlingappa sir, Abhi, where is Abhi? Shivamaga. Yeah. Oh, since morning we want to give many options to the candidates. That's why we are also getting confused. Okay. Then Habib for their support. And also we got many others. Those who lend their hands like to conduct this particular program. They told whatever, whenever required to help us for this program. Dr. Shashikumar sir. Then Dr. Deepak sir, many are like, they just inform like whatever the help required anytime because this want to be successful. And along with me, Dr. Rajesh is there from Sridevi Medical College, Tumkur. We both will be conducting this particular quiz. We want to give you the best session. We hope you will enjoy this particular session. Okay, I want to call all the postgraduates, delegates to come front. Okay, because there is one more round, audience round. Whoever tells first, not first, whoever in the front, we will give prize. If you tell last person telling the answer first, we will see only the front person. Please come forward.
So good morning everyone. Myself Dr. Rajesh B. I'm the professor and HOD. Most of you will be knowing me from the past couple of years because of my involvement in the KSMP.
Echo.
Now last year we wanted to conduct a state level UG quiz competition. So we discussed the same thing with Siddhingappa sir. But sir told it is better to go one step ahead because it's a state level conference. Let us do a PG quiz competition. So we have put in a lot of effort under the support and able guidance of, with the support of Dr. Siddhingappa sir as well as Dr. Abhishek Acharya. Let's hope we will have a good session over the next 1 hour. So once again, our request for all the postgraduates, please occupy the front seats. How to operate?
Okay, can you guess who are the finalists for this today's session? Anybody? Finalists, we had more than exactly 51 teams participated in the preliminary round and we selected only 4 teams. Okay, but all those participated, you are also the winners. Don't worry, your participation is the best thing to do. Any guess which is the first team in the preliminary round to get selected? Team, college name?
No, first slide.
Ghanavi and Vishali from Hassan Institute of Medical Sciences, please come. Second, Yatish Kumar, again from Hassan, and Krishnan from Kolar, STUMC. The second team got qualified for the final rounds. Then Inish Francis and Mandeep from KSMPCON. Yeah. Please come. You will be selecting which table you will be seated. Please come. The fourth team, Rubira Badal and Ishappa from BMCRI. So, you guys, there are 4 teams. We have already prepared you will select which desk you are going to occupy, chairs. Okay, team A, B, C, D, you are going to pick the chairs. One person from each team, please come on the stage. So you can pick one seat. Okay.
So we have planned this system in order to avoid the bias of
you will give
a team getting a tougher question or an easier question. So we already prepared questions. We have divided it into 4 teams. We have made sure that there is uniformity of questions divided across the teams. To avoid this bias, we have calling one member from each of the team and asking them to pick the cheat. So we will divide the team according to whatever the cheats they will be getting.
It is come. All 4 members, each member from each
one
team,
member from
please
each
come.
of the team.
Okay. Can you come here. Come here. 4th team, please come here. You select, everyone select one seat. So that will decide where you are going to sit, that's it. Okay. And that depends on the question. Already questions are framed. We are not going to shuffle. Okay. It is not biased. So we are not going to shuffle. Wherever you go, that particular question you will get. Please come and take one seat. So team D, you will go to the last, okay, place. Last team D. Then Team A. Yatish and Krishnan, Team A. Select. Take.
So the team, respective members, you please join your teammates.
Ainish Francis and Mandeep. Ainish Francis and Mandeep, Team C. You can come and sit. Then, Rubira Badal and Ishappa, Team B. Okay. So, our Team A will be Yatish Kumar and Krishnan, scorer. Please, okay. You can. Along with us, we have scorer.
Dr. Santosh Kumar A. Shetty, who is the professor in KLE JG Triple MC Medical College in Hubli. He has joined our quiz team since yesterday. He, along with Dr. Manu, is left the venue. So we are the 4 members in this team, quiz team. Myself, Dr. Lohit, Dr. Santosh Shetty, and Dr. Manu.
And Dr. Vashinder will be the timekeeper. Okay. So we have, other than us, there are many timekeepers, and the person with numbers in their hands, they will be looking after. Okay. So with your permission, we will start the quiz, sir.
Your questions will be displayed here. You can see. Okay.
Display can be on.
We will give, sir. When we go into individual roads, we will give the guidelines. Okay. So let's start. Let us know how good we know about our medications, all of us, including the professors as
Display
well. Display barta illa pehle.
So we have total 5 rounds. Total 5 rounds. The first round will be the MCQ. We have 2 rounds in that again. 2 rounds of questions. For each right answer, they will get 10 marks. So in the first round, they can score 20 marks, 20 points, sorry. Second one is accidental discoveries.
Team B.
In accidental discoveries, first, again we have 2 set of questions. It's like a clue based. First, we will give the one scientist name, the person who discovered it, along with a clue that will be there. So if they answer that, 30 points. After one clue, if they answer, it is 20 points. After second clue, 10 points. It will be like that. So 2 sets of questions will come. The third round will be the incidents which led to the change in the guidelines. The important guidelines, what we are following. Again, we have only one set of questions, so 10 points each. The fourth round will be the visual round, where there's a visual clue will be there, the picture will be there based on that one question. For each question, each answer, they will get 10 points. Again, there is a 3 cycle of questions will be there. The final round will be the rapid fire. There are 8 questions for each team. And the maximum allotted time is just 1 minute. Within that, they have to answer. And participants, please note that if you cannot answer a particular question, you can pause. So the same question will be repeated later. But the thing is, if you tell the answer, it is done. Once answer is, once you tell the answer, it is done. It is locked. So the total points, the maximum points they can score is 200. Out of 200, okay. And if there is any passing marks, we are not giving the passing points because the problem is we already looked in, there is no pass question from one team to another. The pass questions will be there directly from the members to the audience. If they don't answer, even they can answer, but points is not there for passing score.
So with this, let us start our quiz, the first round, which will be about the multiple choice questions. So the instructions will be that each team will be getting 2 questions. We'll start from team A, then move on to the other teams. And for the second set of questions, again, we'll be coming back to the team A. So for every right answers, we'll be getting 10 points, and there'll be no negative marking. Even if you give a wrong answer or no answer, there is no negative marking. But remember, you'll have only 30 seconds. Once I read out the questions and the options, your time will start, and you'll have only just 30 seconds to give your answers. So team A, are you ready? Shall we begin then? Okay. Here is the first question for team A. According to the Drugs and Cosmetic Rules of 1945, a drug shall be deemed to be spurious if it fulfills all the following criteria except, and the options are, if a drug is manufactured under a name which belongs to another drug, if a drug contains an hazardous excipients or substance in higher quantity than permitted, a drug is substituted wholly or in part by any drug or substances, or a drug purports to be the product of a manufacturer of whom it is not truly a product. Your time starts now. ಏನಾಗ್ತಾ ಇದೆ? No, timer there will be. Time?
Option D.
No, unfortunately you answered after the bell was rung. So your 30 seconds was lapsed. I can't give you. So anybody can give the answer for this? Yes, the answer is B. So team B, now here's your question. Which of the following drug causes hand-foot syndrome? The options are paclitaxel, methotrexate, vincristine, and 5-fluorouracil. All are your anti-cancer drugs. Unfortunately, team B, that is the wrong answer. The drugs which are usually known to cause hand-foot syndrome, the most common will be your 5-fluorouracil. The others were citarabine, capecitabine, and as well as your doxorubicin. So that's the wrong answer from team B. So team C, here is your question. Which of the following landmark document in medical ethics was the first one to mandate the requirement of informed consent from human subjects in research? The options are Declaration of Helsinki, Nuremberg Code, Belmont Report, and the World Medical Association International Code for Medical Ethics.
Option B, Nuremberg Code.
Yeah, that's the right one. Option B is the one. Nuremberg Code was the first declaration which mandated the requirement of informed consent. Later on, it was also adapted by Declaration of Helsinki and all. So team D, here is your question. Which of the following drug that is invented in India is the first one to be approved by the United States Food and Drug Administration? So the options are nifetromycin, artemether, N-metazobactam, or meloxifene. All these drugs are the ones which have been invented in India, but only one has been approved by the US FDA for use in USA. Which is that drug?
Artemether? Option
Unfortunately, that's a wrong answer. The answer is C. N-metazobactam, that is to be meant for combination with cefepime. That is the only drug that is invented in India that has been approved for use in both USA as well as in European unions. So with this, we complete the first set. Now we'll be coming back to the second set, again starting from the team A. So here is your question. All of the following never anti-epileptic drugs modulate glutaminergic or glutamatergic transmission except. The options are topiramate, felbamate, perampanel, and lacosamide. So 3 drugs, they modulate glutaminergic transmission, one does not.
Lacosamide.
Yeah, that's the right answer. We have got topiramate, felbamate, and perampanel, all of one which will inhibit perampanel and topiramate inhibit the AMPA receptors, felbamate inhibit the NMDA receptors, so thereby they interfere with the glutaminergic transmission. Lacosamide is the one which acts by blocking the neurogenic sodium channels. So the answer is D, that is the right answer. So moving on to the team D now. Which is the drug that is used for the treatment of rheumatoid arthritis that acts by inhibiting the Janus kinase 1 and Janus kinase 3 enzymes? The options are ruxolitinib, imatinib, tofacitinib, and afatinib. So all are tyrosine kinase inhibitors, which is the one which inhibits Janus kinase 1 and 3 and used in the treatment of rheumatoid arthritis. There is the clue. Option?
A.
That is the wrong answer, team B. Option A, ruxolitinib inhibits Janus kinase 1 and 2, not 1 and 3. The answer is tofacitinib, which inhibits 1 and 3, and it is used in the treatment of rheumatoid arthritis. So team C, here is your question. All of the following antimicrobial drugs belong to the reserve group in WHO aware list of antibiotics that was published in 2023, except one. So 3 drugs belong to the reserve group, 1 drug does not belong. So the options are colistin, meropenem, linezolid, and tigecycline.
B, meropenem.
Yes, that is the right answer. Meropenem alone belongs to the watch list, not the reserve list. Meropenem in combination with vaborbactam, the combination comes under the reserve list. That is the right answer, Team C. So Team D, here is your question, the last question in the first round. Linezolid, which is used for a long term when we are using it as a therapy of multi-drug resistant tuberculosis, causes all the following adverse drug reactions except. So one adverse effect that is not caused by linezolid. The options are myelosuppression, peripheral neuropathy, optic neuritis, and nephropathy.
Nephropathy. Option D, nephropathy.
Option
D, nephropathy.
Yes, that is the right answer. Linezolid does not cause nephropathy. So with this, we come to the end of the first round. Second and third round will be dealt by Dr. Lohit. We'll be displaying the marks. So this is the points at the end of first round. Team A has scored 10 points. Team B has scored 0 points. Team C is leading now by scoring 20 points, and Team D has got 10 points.
That's great. After like all our neck to neck, just 10 points difference, 20. So the next round, we will give you the clue first. You will have everything there. Okay, you have to just find the answer. So again from A, B, C, and D. So for Team A, okay, sorry. So timings, like if you don't get the answer in the first clue, 30 seconds, like again it will move to the next clue. If you don't answer, then it will be forwarded to our audience, okay? So that is that's how the question, and 0 points, and it will be forwarded to the audience, and time limit 30 seconds for each clue, okay, everyone? So for Team A, are you ready? Yes. So you have to name the drug using this clue. The scientist who discovered the drug is called Paul Link, and that is the clue, the famous picture where the scientist is there. If you answer, you won't get the next clue. Once you answer, that is end. If you want the next clue, we can go to the next clue. So they are asking for the next clue. Skull Paul Link was investigating why cattle were dying from internal bleeding after eating spoiled sweet clover. He isolated this and later modified to drug that we are using extensively. The drug was a poison. It was killing.
Warfarin.
You told answer? That is the right final answer? Warfarin you told?
Heparin.
You cannot change. They told warfarin. Audience? Yes, it was first initially used as a rat poison and later approved as a blood thinner. That is nothing but our own warfarin. So Team A got 20 points. They answered with the first clue. Good. Team B, are you ready? Yes. So you have to name the drug with this. John Cade discovered the drug. If you know, the drug is in front of you. That is the drug. We just extracted from that. That is naturally occurring. The drug is like that. John Cade, 1949. Okay, they want the first clue. John Cade, an Australian psychiatrist, was testing the effects of uric acid on guinea pigs using this drug. He observed that the animals became calm without sedation. Calm without sedation is your important clue. What is the drug? Extensively used. We'll go to the next clue. This drug became the first effective mood stabilizer for bipolar disorder, transforming psychiatric treatment. First effective mood stabilizer for bipolar disorder. Audience are waiting to tell their answers. 30 seconds.
Lithium. Well,
Are you sure? Lithium, they told lithium. Any answers? Yes, lithium is the answer. The team B scored 10 points after 2 clues. Very good. So everyone is getting the answer. The next team, team C, are you ready? Yes. Name the drug. The drug was discovered by Henry Labrault. That is the adverse effect where you can see the pigmentation and also the lens pigmentation can be seen. This is one of the important adverse effect. There are multiple adverse effects with the drug. In 1950, Henry Labrault, the scientist, discovered this drug. Again, now we are using extensively. We'll go to the next clue. Originally tested as an anti-shock agent for surgery, it unexpectedly produced calmness and indifference in patient. The drug with skin pigmentation as one of the side effects and which can produce calmness and indifferences. Next clue. Became the first antipsychotic transforming the treatment for schizophrenia. First antipsychotic.
haloperidol.
Haloperidol, they told any?
Chlorpromazine.
Yes, my sir is always there. We will come with the right answer almost all the time. Chlorpromazine. So that is the birth of, since the first answer is haloperidol, we cannot take that one. Okay. So team C, they could not score 0 points. Please give chocolate to Mahesh sir. So team D, are you ready? Ready for your question? Here comes your next question. Name the drug. Okay, your drug is on there, on the screen. That is the drug discovered by Oscar Labrault. If you know the chemistry, you can read out there. What it is there, that is the answer. Oscar Labrault discovered this drug. Again, it's an accidental discovery. We are using this. The drug is there on the screen. So your first clue. Oscar Labrault investigated for antiseptic use but found to cause sleep. The drug which is causing sleep. You take this drug, it induces sleep.
Chloroform.
Sorry?
Chloroform.
Chloroform is your answer. So, any other answer? So, I will give the next clue. Became the first clinically used sedative hypnotic. Yes, I got. You told after your answer is done, but we will give a chance to the audience. Someone I heard from audience also. Yes, that is the answer, chloral hydrate. That is the first drug we use clinically. Please, your name, ma'am? Dr. Ramsen, please give chocolate to her. So that is the first set of questions. So we'll go to the next set with the same. Again, team A, are you ready? Okay. Your first cue. The drug is extracted from Cordyceps subsalicis from the Sandoz researchers. We are using this. We are using this extensively. We extracted from this. Again, this diagram appears in many textbooks, famous. We are going to the first clue. Sandoz researchers isolated from the fungus for antibiotic researchers. They were looking for the antibiotic research, but they found to suppress immunity. Now we are using to suppress immunity. What is the drug? Extracted from Cordyceps, Sandoz researchers. Immunosuppressant. What is the drug that is extracted here? So next became the key immunosuppressant for organ transplantation.
Cyclosporine.
Cyclosporine. The answer is cyclosporine. This is a revolutionary organ transplant rejection to prevent that. Again, team A got 10 points after telling the answer of with second clue. Okay, team B, are you ready? Yes. Again, this is your cue. Highly explosive, handle with extreme care. Please, please don't tell the answer. I know you all know this answer. It was discovered by Asino Sobrero, but later used by William Murrell. You want the first cue or first clue? They synthesized and noted its explosive nature in 1960s. Then Swedish chemist Alfred Nobel stabilized to create dynamite, making it widespread commercial use. It was used as a dynamite, and Alfred Nobel, what Nobel Prize we are giving now, he used this. An explosive you are using now, with extreme caution we are using for our patient. The next one, all the workers in the Nobel's dynamite factory, they had intense headache on Monday mornings, and also chest pain symptoms returned on weekends. Other days it was normal, but weekends they used to get the chest pain. Important cue, side effects, Monday morning headache. Yes?
Glyceryl trinitrate.
Yes, the answer is nitroglycerin. We will give the points to them. Nitroglycerin. Okay, after second clue they answered. So 10 points to team B. Okay. The next, team C, are you ready? Name the drug. Discovered by Albert Hoffman. You can see the picture and you will get what it is. I'm asking the drug discovered by Albert Hoffman. Specifying. He is a scientist itself, Albert Hoffman. So your first clue, while synthesizing ergot derivatives for circulation, Hoffman accidentally absorbed this drug and experienced hallucinations, that is visual distortions, altered thought, all those. He himself suffered from these symptoms. Our audience are already raising their hands. So your next clue, became the prototype hallucinogen used in psychiatry and neuroscientific research? What is the prototype hallucinogen we are using?
Ketamine.
Yes?
Ketamine.
Ketamine. Any other answer? Yes, everyone, we are getting answers from every place. LSD, LSD, but who told first? Okay, we got two answers at a time. One is from Dr. Industry and another one is from PGC here. We will give two chocolates to both of them. Even I thought I heard it from the first bench, but they are not raising their hands. First is from our own president now, KSMP president. She told, but she is not raising their hand. Okay, good. The next team.
Lohit, I'll disturb you just for a minute. We have an upcoming pharmacologist here. He told attract you.
Yes.
Enthusiastic and upcoming pharmacologist.
Yeah, he raised the hand even just after putting the photo. Okay, are you ready? Team D. Team D, this is your cue. So the side effects you can see. It is a side effect of the drug discovered by Boris Wellcome in 1980s. The classical side effect. After prolonged use, even the darkening will intense. One of the important drug we are using. So your clue, originally made as an anti-cancer drug but found ineffective, but later tested and repurposed when it inhibited viral replication. Now it became an antiviral drug. It was tried as an anti-cancer, again accidentally they discovered this drug to inhibit viral replication. You can use the mic. So next clue, became the first effective anti-HIV drug. The first effective anti-HIV drug.
Zidovudine.
Answer, they told Zidovudine. Is that right? Even where is that kid? He is also telling yes. Zidovudine, cancer drug that turned HIV therapy. And the team D scored after the second clue, they get 10 marks. So, scorer, they're on their tips. So, after the end of round 2, so team, so okay, you can see the grand total at the end. Team A is leading with 40 points now. Team B, Team C and Team D all with 20 points. It is not far or not so near, like everyone is, competition is increasing. We'll move on to the next row. Okay. PPT. Okay. This is for audience round, specifically for you. Okay. What? Name the drug. Genes term, this is not digitalis purpura. Discovered this. Inspired by God's rules. I will tell Mahesh sir not to answer this question. Again, that is also one more clue. Accidentally derived from a plant, but that was used in folk medicine. Yes, the answer is metformin. That's why I asked specifically the dynamic diabetologist. Okay, metformin is the drug. It is initially ignored and later, actually it was tried for diabetes only. Again, they withdrawn and then repurposed as a first line treatment for diabetes, metformin. The next, who answered that? I got the answer. Yes, very easy. Adverse effect, it is there. Yes, the answer is rifampicin. Okay, while searching for new antibiotics, they found red compound. Even the compound was red that was extracted unexpected rifampicin. It is a colorful mistake. What we got? Okay, name the drug. The next one. Here is the drug. Discovered by Barnett Rosenberg. Rosenberg means we will get some idea. Rosenberg, that is the drug itself. Okay, while studying the electric field and bacterial growth with platinum electrodes, released a compound that inhibited bacterial division. Cisplatin. It is now, when it tried for antibiotic, but later it was used for anti-cancer therapy, cisplatin. Good. So we will go to the next round. This is about the incidents or the researchers which changed the guidelines. I know they are all on their tips. Audience, please don't answer that. You all know, I know. Okay? So, are you ready? Each team will get only one question. Right answer, 10 points. Wrong answer or no answer, 0 points. Okay? Are you ready? Team A. What guideline changed? Controversy is thalidomide tragedy. Yes. It was marketed as a safe sedative and antiemetic for morning sickness. And you know, the US's FDA, that is Reviver, Dr. Frances Kelsey, she refused that to be used in US. That's why she was awarded the President Award from Kennedy. Thousands of babies, even now, they are suffering.
Nuremberg Code.
Answer is Nuremberg Code. Any other answers? This is the amendment, Coffer-Harris Amendment of US. This strengthened the pre-marketing drug safety regulations and mandatory teratogenicity testing for all pregnants to be used in pregnancy. So this is the change. In ICH GCP, we will be training. That's why I told okay, team B, are you ready? So what guideline change? Again, the most important Tuskegee syphilis study, world famous syphilis study. Okay, you can see the drugs where, it began in 1932, involved poor black men in Alabama. Researchers withheld the use of penicillin even after it became the standard therapy. And it became the national, international wide condemnation. And then the guideline changed. What is the important guideline which changed with Tuskegee syphilis study? Time is running out. For passing no answer, you can come out with wrong answer also. Even after the penicillin was there, that it was not given. Any answer? So, okay. Creation of institutional review boards and the Belmont report, the mandatory informed consent for all the researchers. We have to give them 2 chocolates. Now only you know the informed consent, mandatory informed consent for after this. Before that there was no informed consent. Next, team C. Recently we got what guideline changed? The controversy is Vioxx trial, rofecoxib. That was the controversy. And I'm giving what is the rofecoxib, the diagram which will tell what is the important problem occurred. Rofecoxib was a COX-2 selective NSAID marketed as a safe treatment, specific treatment. Post-marketing data showed increased heart attacks. The drug was withdrawn after 80 million prescriptions worldwide. The drug was withdrawn. We are using COX-2 very cautiously after this trial. What guideline changed?
NDCT.
NSAID?
NDCT guidelines.
Can you elaborate?
NDC.
So you told answer?
New drug and clinical trials.
So that is all the drugs, that is like especially this rofecoxib, as well as the another trial with rosiglitazone, that is for cardiovascular disease. There is all this, there is a mandatory, cardiovascular outcome trial should be there. If you go to any trial, any conference, they will always tell CVOT, what is the thing? So that is because of after this particular trial. Next, we'll go to the next team, Team D. What guideline changed? That is MMR vaccine controversy. So, in 1998, Lancet paper claimed MMR vaccine linked to autism. So, and the paper was later found fraudulent, retracted. It sparked global vaccine hesitancy. This is the article that is withdrawn. Answer is with you. You are very near to answer with the same clues on the screen. Once, I cannot give next clue, it is very near. Sarla ma'am is laughing because she wants to tell the answer. Your time's up. So after this, it strengthened the research integrity standards and conflict of interest. For every article, we have to submit the conflict of interest. It started after this particular MMR vaccine controversy because many child could not be given MMR vaccine and they started preventing to take the MMR vaccine. After this particular only one study, which was found to be fraudulent. So that was till the next round points we will score. So after the guidelines, no one answered.
No, nobody has got the right answer in this round.
So audience got all the answers right. So after the end of round 3, the score is 40 with team A and 20 with all the other three teams. The next round will be dealt by Rajesh, visual round.
So now moving on to the fourth round. This will be called as a visual round. We will be displaying an image and just one question with that. So we have got 3 questions for each of the team here. One might be like we'll be displaying a building. You have to identify which building it is, or sources of the drug, maybe animal or a plant one, or the instruments that you'll be using for the postgraduate practicals and all those things. So each team will be getting 3 questions. You'll be awarded 10 points if you get the right answers, and there'll be no negative marking. If none of the team answers, that will be passed on to the audience. And you have got 30 seconds to answer these questions. So team A, are you ready? Shall we begin? So the question for team A is, this is the image of the Brazilian pit viper. Yes? This is a Brazilian pit viper. A drug was discovered from this.
Anti-snake venom, ASV.
That is the wrong answer. The drug was discovered from the peptide that was identified in the snake's venom. It is used to be, it is no longer used. It was a better drug to be used as an anti-hypertensive drug. Now, you have got given the wrong answer. I'll give you another option. You'll not be getting any marks for this. But can any of the team guess which was the drug? Yes, captopril is the right answer. Way back in the year 1975, it was discovered from the peptide which was obtained from the venom of this Brazilian pit viper. So, team A, you got the wrong answer. So, team B, here is your question. So, this is known as a Pacific or Western heave tree. So, from the bark of this tree, a famous drug was discovered. I'm not going to tell which class of drug because that will be the leading answer. I told you it is the tree's name as well. Pacific or Western heave tree. I'll give one more clue, an anti-cancer drug. That is the wrong answer. Colchicine is not the right answer. Any other team? Yes, paclitaxel is the right answer. ಇಲ್ಲಿ ಬರ್ತಾ ಇದೆ ಅಲ್ಲೋ ಪವರ್ ಹೋಗಿದೆ ಟಿವಿ ಸ್ಕ್ರೀನ್ ಬರ್ತಿದೆ ಅಲ್ಲಿ ಬರ್ತಾ ಇದೆ.
Audience to see. ಇದು
So the right answer here is paclitaxel, which is an anti-cancer drug. Now moving on to the third team, Team C. Here is your question. So you got a boy who is in the initial picture is very lean and has become a normal boy in the second picture. So this boy was the first person to be administered with insulin. He was suffering from type 1 diabetes mellitus. What is his name? We all know the one who discovered this insulin and all, the Nobel Prize controversy, everything we know. What is the boy's name? Sir, this. Except for Mahesh sir, anybody can answer this.
Randall.
Sorry?
Randall.
Anybody else? Any other team? Anybody from the audience? Yes, Leonardo Thompson is the right answer. I'll get one more question. You might have seen that photograph with the Banting and Best with the dog. Can anybody name the dog's name?
Marjorie.
Marjorie is the right answer for that. But unfortunately for this question, you'll not be getting any points. So the right answer is Leonardo Thompson, who was administered with insulin way back in the month of January in 1922. And can you guess for how many years after receiving this insulin injection he lived? Later on he died because of some other complications, but for how many long years he took this insulin and lived a normal life? He was administered this insulin at the age of 14 years and he died by the age of 27 years because of some other complications, respiratory complications, not because of the complications associated with either insulin or type 1 diabetes mellitus. So Team D, here's your question. So identify this famous American pharmacologist and biochemist. The clue is there. He has been awarded with the Nobel Prize in the year 1994 along with Martin Rodbell. An American pharmacologist and biochemist. He shares the name with his father. Both father and son have got the same name. One minor difference.
Goodman Gilman.
Can you give the full name?
Alfredo Goodman Gilman.
Yes, that is the right answer. Alfred Goodman Gilman. And what is his father's name? Father's name? His father's name. Which Jesus? First G or second G? First G or second G? And the father's name? Alfred Gilman was the father's name. He along with Goodman and Gilman. So he named the son as Alfred Goodman and Gilman. And why were they awarded Nobel Prize? Yes, for the discovery of G protein and their role in signal transduction in the cells. So that is the right answer. Alfred Goodman Gilman. Team D, you got the right answer. Now we'll be coming back again to the Team A. Here's your question. Identify this building. If you observe closely, the clue is in the picture itself. And I expect none of our faculty members, please don't answer. Let the PGs answer this. The clue is there in the picture if you observe closely.
we are celebrating this every year. Clue is there.
Don't give the clue. Don't give the clue. Any other teams? 16th of October, we will be celebrating one day, and it was discovered way back in the 1846. So there is a clue. 16th of October 1846, and 16th of October every day we will be celebrating World Anesthetist Day. So can you give the answer now? Or any other team?
World Anesthetist Day.
Anybody
Why?
from the audience? PGs? No, PGs. I already told you this is only for PGs. No, you are like faculty sitting along with PG, I will not consider that. Any other PGs? So many clues. Anesthesia. Which anesthesia was the first one to be discovered? So what is this building? Yes, that is Ether Dome. Where is it situated? Any idea? Massachusetts General Hospital in Boston, USA. So team B, okay, this is the answer is Ether Dome. So team B, here is your question. I think most of you can guess this. Identify this building. The clue is there again in the building, in the picture itself. Please, faculties again, please don't answer this. Identify this building. If you observe closely, the clue is there in the building. It is displayed on the building itself. Any other teams?
Uppsala Monitoring.
Yes, this is the building in Uppsala Monitoring Center. In which country it is situated? Sweden. And what is its role? Yes, it's a WHO collaboration center for ADR monitoring. Okay, this is a Uppsala Monitoring Center that is situated in Sweden. So that is a wrong answer. Please note it, they are not given any answers. So team C, here is your question. Identify this instrument. There's a rat in the instrument.
Actophotometer.
Yes, that is the right answer. Did anybody hear what answer they gave? Actophotometer, what is it used for? Mike.
Locomotor activity.
Locomotor activity in rodents. Yes, that is the right answer. Actophotometer. Now team D, coming to team D now. So identify this instrument. No answers? Any other team? Or anybody from the audience? No?
Coloring.
Anybody? Deepak sir?
Hey.
Anybody? Postgraduates? No? Sarala madam? Anybody? Radhika ma'am, Hema ma'am?
Flame photo.
This is flame photometer. Okay. Now let us go to the third set of questions. Team A, here is your question. Identify this. No, this set will be about ADRs, adverse drug reactions. So we'll be displaying the ADR images. So identify this adverse drug reaction.
Livido reticularis.
Yes, that is the right answer. This is livido reticularis. And which drug causes this?
Amantadine.
Can you tell something else about this? Anything else? Why does it cause? Why does he score, or what is the pattern there? Anybody from the audience?
Reticulous
Yes. So the right answer, please note the scorers. The team A has given the right answer. This is levido reticularis caused by amantadine. So team B, here is your next question. Identify this adverse drug reaction. The clue is there in the picture itself if you observe closely.
Lichen planus?
Sorry?
Lichen planus.
No, that is the wrong answer. You just see, have a look at that peripheral smear. Anybody? Peripheral smear? Peripheral smear. The clue is there in the peripheral smear. Exactly what syndrome? I gave the clue as a syndrome. Yes, vasculitis, there is eosinophilia will be there. Church-Strauss syndrome. And caused by which drugs? Montelukast, leukotriene antagonists, leukotriene receptor antagonist, montelukast is the one which will be causing this Church-Strauss syndrome. So scorers, please note they have not given any right answer, team B, so 0 points. Now moving on to team C. Identify this adverse drug reaction. Have a look at the color of the hands.
Gangrene, ergotism caused
Sorry?
by gangrene of.
Now that is a wrong answer. Team B, you are talking about something else, some other drug.
Sir.
Yes, okay. Anybody from the audience? They have given the right answer, but I just want to give one more opportunity to the audience. What is this? No, sir.
Sir, purple
No.
hand and toe syndrome.
Doxorubicin.
Again, which drug?
Warfarin.
No.
Sir.
Phenytoin-induced purple glove syndrome. And why does it occur? This is a purple glove syndrome which is caused by phenytoin. Why does it occur? Is it because of oral administration or IV administration of phenytoin? Infusion related. And what exactly does it happen there? Any idea? When phenytoin extravasates into the tissues, so what will be happening over there? So there will be a lot of swelling, there will be irritation in the local area, distal to the area where you will be administering this phenytoin. So this is purple toe syndrome, which will be seen when there is an extravasation of phenytoin when it is administered through intravenous, either injection or infusion. So team D, here is your question, the last question in this round. Identify this adverse drug reaction. Again, look at the color of the toes. This is a rare adverse effect seen with one of the commonly used drugs. Any guesses from other teams?
So gangrene which arm?
Gangrene.
Occurs due to?
Gangrene.
Occurs due to which drug?
Ergot.
No. Anybody else? Due to? Purple toe syndrome, that is the right answer. Kesa, can you tell me which drug causes this and why?
Warfarin. Warfarin.
And why does it occur, sir, with warfarin? So imbalance in the coagulatory system, yes, it interferes. And one more explanation, sir. It causes microembolization. Whenever this atherosclerosis is there, that is what? So the minor arteries in the toes will be they will be occluded, leading to this purple toe syndrome. So the right answer is purple toe syndrome causing by warfarin, but team D, they did not give the right answers. So with this, we come to the end of the fourth round for the teams. Now we will be moving with the audience rounds. We have got certain questions for the audience as well. So the first question is, identify this company, pharmaceutical company. Yes, sir? I think in future he will be opening his own pharmaceutical company, sir. Pfizer is the right answer, but Ishanu Shastri gave the... Okay, now the chocolate will be going to that our young pharmacologist, Pfizer. So again, identify this pharmaceutical company now. Sun Pharma, it's... Audappa, Sun Pharma ne kanappa. So we got the last question for the audience. Identify this picture. Have a look at the uniforms of the convicts. Nuremberg. And now he'll be barred from giving any answers now. The right answer is Nuremberg trial, which led to the development of Nuremberg Code later on. So with this, we come to the end of the fourth round. Now if the marks are ready, we will be displaying the marks before we go to the final round, that is rapid fire. So now we have got Team A leading again with 50 points, followed closely by Team C with 30 points. Team D has also got 30 points, so they are joint second position. Team B is trailing by 20 points. So far we have completed 4 rounds of 120 points. So this is your standing. Now we'll be moving on to the last round, rapid fire round, which will be having 80 points. So make strategies, analyze whether you want to take risk in this rapid fire round or not. You have to be on your toes. You have to be giving your answers rapidly. And this is a make or break round. Even Team D, you have got Team B, you have got the opportunity, maybe at the end of this round, you'll be the winners. We don't know. Okay?
So this round can change everything, because you will get total 8 questions. So each carries 10 points. Anybody can score 80 out of 80. So this will determine who will be in the first, second, third, fourth, like that. Okay, this is a rapid fire round. So we'll go from Team A, B, C, D. Same. You will get 8 questions. Time allotted per question maximum 15 seconds. You can pause because we want 2 minutes total time will be there. Among that you can answer whatever the number of questions. Points will be allotted, and for this round, Dr. Rajesh as well as Dr. Vashinder, they will be checking your answers. Okay, at the end we will tell, because there should not be any controversy that I told and I missed, because continuously with no time we are going to give you 8 questions together, right? Are you ready? Instead of 1 minute, it is increased to 2 minutes, because question also it will carry some time.
One more thing is that if you don't know the answer, you just say we will pass on the answer, and if time permits, after completing the 8th question, if the time permits, we will come back to the questions that you have passed on. If you give the wrong answers, that will be the end. We will not be asking that questions again, okay? If you don't know the answer, you just tell we will pass on.
Yes. Yeah. No, if you tell the wrong answer, we'll go to the next question. Whatever wrong or right answer will go to the next question. Okay? Are you ready now? We will start the last round. Okay, Team B. The first question. What is the full form of CCSEA? CCSEA.
Committee for Control of Safety and Experiments on Animals.
So the next question. The EMPA kidney trial demonstrated renal protection with which drug? Empagliflozin. Which oral GLP-1 receptor agonist was approved in 2024 for type 2 diabetes as well as obesity? Just previous session we heard about this.
Tirzepatide.
Norepinephrine is used for neurogenic shock. True or false?
Pass.
Which new drug delivery innovation allows once yearly insulin dosage development? 2024 preclinical study.
Pass.
What is the controversy surrounding off-label use of semaglutide, Ozempic phase? Previous session we heard about it. Semaglutide, Ozempic phase. Which anti-cancer drug causes pulmonary fibrosis?
Bleomycin.
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 What does Schedule Y of Drugs and Cosmetic Acts deal with?
Orphan drugs.
Sorry? Orphan drugs, you told?
Sir, we'll go with the question. Question 4.
Yeah.
I'm going to answer that. That is false.
They told false for question 4?
False.
Yes.
Which new drug delivery innovation?
New drug delivery innovation. Okay, your time's up. Any other members? Can answer? Okay. CCSEA.
Committee for Control and Supervision of Experiments on Animals.
Perfect. You told safety. It is supervision. Committee for Control and Supervision of Experiments on Animals. So it's not safety, it's supervision. Okay. So we cannot give empagliflozin. That was the right answer. Which oral GLP? Orforglipron. This was it was discussed in the previous session. Then it is, you told false, it is true. Then which new drug delivery innovation? This is the implantable insulin microchips with controlled release of nanovalves. We are expecting, like it is in the preclinical, but as a once yearly insulin dosage, it will change the entire setups of management of diabetes. And controversy with Ozempic phase. In US market, they are using widely even without the clinical approval, that FDA approval for weight reduction. So this has led to the shortage of this drug and misuse of this drug. Even diabetic patients are not getting the drug for their use. That is a controversy. No, the phase, Ozempic phase, when it started semaglutide, everyone started using the drug. That was the controversy. Then now it got approved with lower dosage and dosage. Then anti-cancer drug, you told the right answer, busulfan or bleomycin, that is, you can get. Schedule Y deals with clinical trials and new drug approval. Okay.
So team A has got 2 right answers, so you'll be getting 20 points out of this 80.
Team B.
So moving on to the next team, that is team B. Are you ready?
Yes.
Okay. So here is your first question. What is the full form of CDC?
Central Drug Standard Control Organization.
That is the right answer, team B. Now moving on to the second question. In 2023 ESC hypertension guidelines, the first line therapy includes the combination of which of the antihypertensive drugs? Combination. Your time running out?
Pass.
Okay, pause. Third question. Which long-acting HIV therapy uses cabotegravir and relprevir combination injections?
Pass.
You are pausing this. Fourth question. Ropinirole is approved for use in restless leg syndrome. True or false?
True.
That is the right answer. Fifth question. What is the role of pharmacogenomic testing before clopidogrel use as per the ACC guidelines 2024?
Pass.
Next question. What principle underlies right to try legislation in experimental pharmacology? Sorry, pharmacotherapy.
Pass.
Okay. Seventh question. Which membrane receptor is blocked by sunitinib?
Pass.
Eighth question. According to the NDCT 2019 rules, how many days prior to the date of expiry of the registration, the Institutional Ethics Committee has to apply for renewal?
90 days.
90 days. That is the right answer. Now coming back to the questions that you have passed, the second question, 2023 ESC hypertension guidelines. So what is the combination? No, they are belonging to the same group. ARB or ACE plus which drugs?
Calcium.
So your time's up. This is either ACE inhibitors or ARBs in combination with CCBs or thiazide diuretics. That is the answer. So here is your answer. The first question, you got it right, Central Drug Standards Control Organization. The second question, the option answer was either ARBs or CCBs or thiazide diuretics. The third question, that is Cabenua, which is monthly or bi-monthly dosing. Yes, Opinarol, the fourth question, that is true, to be used in the restless leg syndrome. The fifth question is that the pharmacogenetic testing before starting therapy with clopidogrel. Clopidogrel has got drug interaction with the drugs which will be inhibiting this cytochrome P2C19. So that one. The sixth question, right to try legislation. Here this thing is, patients who have got terminal illness, they can access even the unapproved drugs outside the clinical trials. So that is the guidelines. The seventh question, sunitinib, it blocks the VEGF receptors. The last one you got it right, that is 90 days before the expiry, the IEC has to apply for renewal. So you have got, team B has got three answers right, so you'll be getting 30 points.
So next, teams, are you ready? Okay. So the first question, what is the full form of PETA? PETA.
Pass.
GLP-1 receptor agonist showing the reduction in major cardiovascular events in diabetes. What is the drug or the trial?
Semaglutide. Next. Semaglutide.
Semaglutide.
No, they have given the answer, you move on.
Okay, next one. Name the novel RSV vaccine approved for the older adults and pregnant women. Approved. Granisetron is preferred drug in the managing delayed chemotherapy-induced nausea and vomiting. True or false? Granisetron?
True.
True. Which recent nanotechnology-based innovation improves CNS drug delivery across blood-brain barrier?
Pass.
In pharmacovigilance, what does the term black triangle denote in EMA labeling? Black triangle, what does it denote?
Pass.
Which antiretroviral drug should never be reintroduced once to the patient who develops hypersensitivity to it? Once hypersensitivity, never tried. Never should be tried. According to NDCT 2019 guidelines, what is the maximum number of members required to constitute institutional ethics
7.
committee?
Minimum.
Sorry?
7.
7. So we can move to the past questions.
Fifth one is liposomes.
Fifth one?
Liposomes.
Ribosomes. Next. Black triangle.
First question.
Sixth question. First question. PETA.
Black box warning that the
Seventh question.
So your time's up now. So the answers are on. Okay, here are the answers. PETA, you didn't answer. There is a people for the ethical treatment of animals. GLP-1 receptor agonist, liraglutide. They told liraglutide or semaglutide?
So that's the wrong answer.
It is the wrong answer. You told leader triangle, that is a liraglutide. The novel RSV vaccine approved for both pregnant as well as older women, that is from GSK and Pfizer, Arexvy and Abrisua. Granisetron is the fall answer. Pelonosatron is commonly used. That is the drug of choice. Then blood-brain barrier, you told ribosome, it is exosome-coated nanoparticles targeting drug transport. Then in a black triangle, it suggests a drug under additional monitoring for safety. For all those drugs, the black triangle will be there. Abacavir is the drug which should not be reintroduced again if they develop any hypersensitivity. And 7 members for minimum number required, that is true. So you got semaglutide. Yeah. Yes. In both the other drugs also shown, okay, leader triangle. So we'll give points to that also. Both those drugs, all, yes. Yeah. it became the class effects after this trial. It was again all the drugs have been tested. So we'll give points to two questions, that is semaglutide, the second one, and 7 members for institutional ethics committee.
So
20
Team C
points.
has got 2 right answers, 20 points for them. So moving on to the Team D now, the last group, the last question, the last set of question in this PG Quizeria contest. Team D, are you ready?
Yes, sir.
Will we start then? So here is your first question. What is the full form of ICH GCP?
International Committee for Harmonization, Good Clinical Practice.
Okay, that is the right answer. Second question. The current WHO guideline, according to the current WHO guideline, which is the first line drug for multi-drug resistant tuberculosis?
Bidaqualin,
That is the right
clofazimine.
answer. Third question. Which monoclonal antibody was approved for migraine prophylaxis?
Leronlimab against CGRP.
That is the wrong answer. Fourth question. According to the ICMR guidelines, the ethics committee should be headed by the institution, head of the institution. Is it true or false?
False.
That is false. Audience, please keep your voice down. Fifth question. What is the role of Darwin EU initiative in modern pharmacovigilance?
Pass.
Pass, okay. Sixth question. What is the 2023 WHO stance on AI-generated drug data in clinical research?
Pass.
Okay. Seventh question. Which WHO database collects global ADR reports?
Digiflow.
That is the wrong answer. Last question. What is the time limit to report an adverse drug reaction to the Pharmacovigilance Center? Your time is running out. Tell me how many days?
Pass.
Pause. Okay, now coming back to the questions that you have passed, the third question, which monoclonal, sorry, that is the wrong answer. Fifth question, what is the role of Darwin EU initiative in modern pharmacovigilance? Again, I'll go to the eighth question. How many days ADR should be reported within how many days of occurrence of ADR?
$21 days.
Sorry?
21 days.
That is the wrong answer. Now going to the sixth question. 2023 WHO stands on AI-generated drug data in clinical research. Rohit? So your time's up. Team D, you have got 3 right answers, and here are the answers now. The full form of ICH-GCP, that is International Council for Harmonization Good Clinical Practice, that is the right answer. The WHO guidelines, the first line, anti-TB drug for MDR-TB, bedaquiline, that is also right answer. Third question, you did not give the right answer. Fourth question.
I told Leronlimab. I told Leronlimab.
Okay, I'll consider that then. Fourth question, yes, you give the right answer, that is false. It should not be headed by the head of the institution. Fifth question, the real world evidence network for continuous post-marketing drug safety evaluation across the European countries. Sixth question, the AI, the artificial intelligence assisted outputs must undergo full human verification before clinical or regulatory use. The seventh question, you told VG-Flow. That is a software, that is not a database. VG-Base is the one. Final one, you told how many days? In ADR, the maximum is 15 calendar days. Within that, we have to report it. So Team D has got 4 right answers, so 40 points for you. So can we have the display of the final points?
So sorry you all saw the answer. It was unexpected, and today morning we prepared drugs based on the previous things. What if 2 teams score equal marks? Okay, we planned many things, but you can put the score on.
We'll have a display. Then we'll see.
Score on, please.
Please display the scores.
So after final round, 2 teams standing first and 2 in second.
A and D at 70 points, B and C at 50 points. Now, how to differentiate which is the better team? How to differentiate which is the better team now? Yes, we have planned for a tiebreaker as well. So please display the screen.
So, okay. There are two teams, like we will call these two teams the first and second, to decide the first and second team.
So first we will have a tiebreaker between the top two teams, that is A and D, which are tied at 70
only
points.
A and D, so you can switch on both A and D.
This
Use
is
the
not
mic.
for team B and C, okay? Only for A and D.
Okay. First we'll go to cell. Okay, you are going first.
So, tiebreaker. So, what we have planned is, we'll be displaying a question and the words, the letters in the particular drug name will be arranged in haphazardous order, in a jumbled way. So, based on the question, the clue, you have to find out the right drug name. And whoever answers first will be the winner. And another thing is, if you give the wrong answer, you will be the loser. So don't be in a hurry to give the answer, analyze it, and only then give the answers, okay? Even if you don't give the answer, if the other team gives the wrong answer, the team that does not answer, those will be the winners, because they'll be analyzing. It's better not to give a wrong answer, it is better to keep quiet. Is it clear now? Team A and Team D, okay? So this round is known as jumbled letters, okay? You got the clue? So we'll be having this, the drug name, the letters will be haphazardly arranged. So we'll be giving you a clue and the teams has to identify the right drug. Okay, sir, we will consider that 30 seconds will be the time limit again. 30 seconds. So team A and D, are you ready for the first question? Shall I display it?
Yes, sir.
Okay, this drug is used in early cancer chemotherapy induced nausea and vomiting. Be very careful. They don't answer.
30 seconds.
They don't answer.
Next question.
Nothing answer. Then second round is the first answer. So time's up. Any guesses from the audience?
Actually, they are afraid of telling the wrong answer. That's why they are not attempting also.
Now, we'll be going to the
This
next
was
question.
there previously, in previous question we asked about pelanosatron. But, okay.
Now, in this round, you have to answer. We cannot go on like this for each and we will be going like till evening. So one of the team has to answer this, the next one, okay? If you don't answer,
we'll go to another question. No, this is the last option.
We will pick. We'll make you pick a cheat.
See, we want to select the third place also. We'll give them chance then.
If you don't answer for the next question, we will make you people to pick cheat, and based on this, we will declare the winners. Audience, is it okay? Because we cannot go answer. Toss, sir? Toss or cheat? Okay, sir. Anybody has got coins then? We'll keep it ready? Okay.
Plenty of.
So going to the next question now. This anti-diabetic drug decreases the blood sugar level whose action is independent of insulin and can cause pronounced gangrene as an adverse effect. Your time is running out.
Dapagliflozin.
Yes.
Team A?
Team A told the answer dapagliflozin first.
Is it the right answer, audience? Within microseconds. Not even 1 second. You
That's why
missed out the first place within microseconds.
Team D, don't worry, we both are from same college, Hassan.
We can give prize only for the one team as a first place team. We cannot give for both. Unfortunately, microseconds. That is the importance now. Okay.
Actually, beginning only he started mumbling to his friend, but he didn't tell the answer. After I was expecting him to tell the answer. After 10 seconds, he again cross-verified and told the last answer. So anyway, Team A is the first, and Team D is...
Give them a big applause now. Now let us break the tie that has happened between Team B and Team C for the third place now. Okay, again
You'll
same
get
thing.
only one question. You have to answer or else toss.
Same. We'll follow the same system. We'll have two questions now. If you don't give the answer for the first question, next question you have to give, or else we'll go for the toss. Is it clear? So team B and team A, please maintain silence. Team B and team C, are you ready for the question? Shall we display the question? This drug is used in premature labor. Audience, please. Mahesh sir, please keep your voice low. It is audible here. Yes, team C, any answer?
Inositaban.
Sorry, once again. That is the wrong answer, team C. Any answer? Atosiban. The right answer is atosiban. So, no, they gave the wrong answer. They gave the wrong answer. They are the right. They are the winners. They are the third place now. So that's why I told you, be careful before taking the risk. So now we have broken the tie. We have got Team C at 4th place, Team B at 3rd place, Team D at 2nd place, and the winner of this first state level PG quiz competition conducted under the banner of KSMPCON. We have got Team A,
Yatish
who
Kumar
have won just
from
the
Hassan,
fraction of
Yatish Kumar and
seconds.
Krishnan from Kolar. Combination of two colleges. That is the only team with two different colleges. That's why more knowledge. Two different colleges, and it was really wonderful. And this guy, he knew the first question answer also, Pelanoceton, but scared of telling the wrong answer. And the next round they answered, it was, you missed in some letters. Okay, so at the end of all the rounds, thank you very much. We will announce the names. Team A, Yatish Kumar ji and Krishnan, they are the winner.
Please give them a big round of applause.
Team B, Ghanavi, Dr. Ghanavi and Vishali, again from Hassan Institute of Medical Sciences, they scored 2nd. Team B, Rubera Badal and Ishappa from BMCRI, they are 3rd. And Inish Francis and Mandi from KS Agde Medical College, they stood 4th place. So congratulations for all the participants, winners, you are all winners. Okay.
I got one more question for the tiebreaker. This is only for the audience now. Sir?
Next session.
Okay, we'll go. Can you guess this one? Okay, we thank everybody, the organizing team for giving the opportunity. This is a teamwork. This is not an individual work. This is a teamwork for giving this opportunity to conduct this first postgraduate quiz competition in this conference. Thank you, Dr. Sidlingappa sir. Thank you, Dr. Mahesh sir, and Dr. Abhishek as well, and all the team of this Subha Institute of Medical Sciences. Once again, we thank you, myself, Dr. Lohit and Dr. Santosh. We thank you wholeheartedly for giving this opportunity. Thank you, sir. Prize distribution,
Prize we will distribute. Yeah, you want to tell? Yeah, we will send the feedback. Yeah, we want to tell.
I'd like to thank our guide, Dr. Deepak sir. He's been very excellent with academics and very friendly with the PGs. Thank you, sir. It really motivated me. I did.
Okay. Sir, we want a photo with PIS team and organizers.
I request Dr. Siddhalingappa CM, Dr. Mahesh GK, Dr. Abhishek Acharya to come up on the stage.
Please come on. ಒಳಗೆ ಬರಬೇಕು ನೀಲ್ ಡೌನ್ ಮಾಡ್ಬಿಡಿ ಇಲ್ಲ ಬರಮ್ಮ ಇದು ಸೆಂಟರ್ ನೋಡಿ ಇವರು ಕರೆಕ್ಟ್ ಇದ್ದಾರಾ ಚೆನ್ನಾಗಿತ್ತಾ ಸರ್
ಸೂಪರ್ ಚೆನ್ನಾಗಿ
ಥ್ಯಾಂಕ್ ಯು ಮ್ಯಾಮ್
ಹಿಂಗೆ ಕ್ಷಮಿಸಿ
Should be relaxed.
The consultant general surgeon and owner of Shanta Nursing Home, Shivamogga. Dr. Shekhar has over 25 years of experience in biomedical waste management and is the founder, president and patron of Shushruta Biomedical Waste Management. He has delivered guest lectures across Karnataka and participated in numerous state, national and international conferences. He played a pivotal role in formulating the 2016 biomedical waste draft rules and continues to advocate for non-wind technology and zero waste discharge practices. He is actively working on non-wind technology for BMW, zero waste discharge and creating awareness about household biomedical waste management. So the stage is yours.
First of all, I would like to thank the organizers, especially Dr. Mahesh, for giving me the opportunity. Before that, why I am here? And as you know, you are all experts in the drugs. You are the custodian of the drugs that all the medical profession prescribes. Do you agree with me or not? You are all the authority on the drugs and expert. Your opinion is final as far as the drugs is concerned. And once we use the drugs, after that, what will happen? It's whose responsibility? It is your final judgment that goes a long way in the biomedical waste management, especially the drugs. What is a waste? I need one or two volunteers. One volunteer, please. Please, just take this. What is this? It is a syringe. Is it waste or a product? After using. Now it's a product. So you open this. See, he opens and either draw the blood and give the injection or draw the blood. And this is the swab. Okay. Now, what is this? It is a waste. It is a waste. It is a biomedical waste, which comprises of, that is sharp, and this is plastic, and this is rubber, and this is a swab. Whether this is infected or non-infected? Yes. Suppose your father or somebody are having a HIV infection. Patient, okay. Okay. Because he'll be father of some, this thing. How you look after them in the house? Say for example, diabetic foot is there, diabetic ulcer is there, you have to do dressing. Yeah, that means you have to take care of yourself first. Protection of the self first. For that, what you will do? You will wear the gloves. Okay, please. One sec. Now, you wear. You can wear it now. In the waste management, or whether biomedical waste management, the key principle is segregation or the separation. Is the key principle. What is this type of waste is called? Whether it is a biomedical waste or non-biomedical waste? This is a non-biomedical because it is just a cover. Even this also. Whereas this gloves is a biomedical waste and you categorize it. Biomedical waste this all comes under Environment Protection Act. That is, it applies to almost all the individuals who are living in India. And we are all part and parcel of the environment protection. It is the responsibility of every individual to protect the environment. This biomedical waste rules comes under Environment Protection Act. And this is the latest guidelines. Next one. Okay. See, as far as the definition is concerned, it's a term used to describe any waste that is generated in the diagnosis, treatment, or immunizations of the human beings or animals, in research pertaining to their or in the production of testing the biologicals or in health camps. That is the definition. That means the law applies to whoever generates the biomedical waste, they have to comply with the biomedical waste rules. But these are all things, it applies to everybody. So this is the segregation. There are different types of waste you have to segregate. Why you have to segregate? One simple example. Halu masaru ottige khadde idea. Halu ek separate irbeku, masaru ek separate irbeku. Because both have different characters. In the waste generated, it's only 5 to 10% is infectious waste. If you mix with the general waste, other waste, whole thing will be infectious. That is the aim of segregation. What is the aim of segregation? Is to separate the infectious state which is hazardous, which is infectious, which spreads the infection to the other persons, so that we have to separate, that is segregate the waste based on the criteria. That is the basic principle. Then these are different type of categories and okay. And these are symbols, that is biohazard symbol is a must. And yellow, all these things, I think. Especially cytotoxic drugs. These are things you have to be careful because you are the custodian of cytotoxic anti-cancer drugs. Anyone for the court also, they will ask your opinion. Doctor, how do you dispose of cytotoxic drugs, anti-cancer drugs, chemotherapy, whatever they call it? Your opinion is final. How do you dispose it? Cytotoxic drugs? Any idea? First thing is the isolation. Segregate. You have to separate it from the rest. Just he is like a terrorist. They are like a terrorist. Once after the use, they are like a terrorist. Because by chance, any of our children or anybody for that matter, if they come in contact with the cytotoxic drugs, they create havoc. Because cytotoxic, they are lethal to all the cells, even normal cells. And these and genotoxic chemotherapy drugs are all, even the blood bags, all the things. And once it is generated and segregated, it has to be transported. Transported in a closed vehicle, closed container. And see there. And this is the recording system. This is the must. As far as biomedical waste management is concerned, whoever generates, they have to maintain the records. How much they generate, to whom they have handed over, what they have done. As per the law, it is the generator responsibility to treat the biomedical waste. It is the generator responsibility, not the treatment person who treats it. That as per the law, you are held responsible for irresponsible disposal or management of the biomedical waste. That is the law. For that, you have to have a record. And there is no spillage. And this is our vehicle, Sushruta vehicle. And this is indiscriminate use. No question of open burning. Burning is a crime. If anybody comes in contact or put a case, you will be put behind bar for 3 years. And how do we treat it in our plant? Basically, biomedical waste is infectious, toxic or hazardous in nature. What is our duty? To make infectious waste into non-infectious waste. What are the methods available? All of us know it is autoclave, that is the age-old method. That is the first thing. Second is incinerator. Anybody, you heard of it, incinerator? It is a scientific burning, you can call it as scientific burning. Other methods are microwave, hydroclave, or different methods are there. Practically, we are using incinerator. Incinerator, it contains minimum 2 chambers, that is primary and secondary. Primary chamber around 800 degrees centigrade, secondary contains around 1100 degrees centigrade. Autoclave, all the details you know, only thing what you have to make sure you have to do a spore test, whether there is infection left or spores is left or not. You have to do a periodical spore testing in biochemistry. That is important. And regarding hazardous waste, all your cytotoxic and they comes under hazardous waste. Hazardous waste should be handed over to the hazardous waste management cell. That means that it has to be incinerated under at least 1500 degrees centigrade incinerator.
What do you do with that ash, sir?
Yes. Yeah. Now the end product, see, once, because there is a story behind it. Once we started in 2000, about 20 years back, we have gone to the industrial department to give us a land. Well, they asked us, Doctor, what is your project? What is your product? Our product is ash only. Now, how do you return our money? They refused to give us the loan. Later, the DC come to our rescue. It's a new industry. It is a service industry. Then we got the loan. We asked, it was considered earlier a domestic waste, now considered as a hazardous waste. It has to be sent to the hazardous secured landfill. Secured landfill. There is only one place in Karnataka, that is in Dabaspete, near Bangalore, Tumkur. Secured landfill. So far, we don't know how to treat it. We are dumping it in a secured landfill. They dig it and put a impermeable layer and fencing it. They keep it till the toxicity goes off. That is the standard method now at present. So, in nutshell, it's very simple. Whoever generates, it is their responsibility. You have to make the infectious non-infectious, hazardous and non-hazardous, and you hand over to a authorized person to do all the treatment part as per the guidelines of the Biomedical Waste Central Pollution Control Board role. Now, that is in nutshell. We are running it for past 21 years, I think so, in the plant. In Shimoga itself, per day, around 2 to 3 tons of biomedical waste is generating. Almost every year, that waste generation is increasing because of the tertiary care treatment and the use of all disposables. There is no other option except for a standardized and compulsory waste management in itself. Thank you. Any questions, please? It is the municipality. Or there was still a confusion. Even the syringe cover, it is also domestic waste, we call it as. Earlier it is classified, it is a domestic waste. Yes.
The outlet. After that, only the empty available. So that should be handed over.
Any biomedical waste should be handed over to the CEO.
So that, I think that should be biomedical.
Biomedical waste only. Now, the latest Yes, please. See, that is comes in this latest rules. It is household biomedical waste management. In the beginning only I told it is everybody's responsibility. Yes. Yes. Can it over to for us only? Allah, see for that patient, that's why household biomedical waste are called. Household biomedical waste management. See, waste management is not confined to the hospitals now. Almost every house is generating biomedical waste. See, after 60 years, almost every alternate person is a diabetic patient. He takes an insulin syringe, insulin, he uses it, and he uses tablets. Suppose even the cancer patients, they consume it, they are leftover or discarded medicines. As you said, they use half the drugs and keep it aside. And what will happen to them? That's why the latest law says, now we have got understanding with the municipal corporations. It is their responsibility to collect the biomedical waste and hand it out to the person who are managing or treating the biomedical waste for us. In the beginning only I told again, biomedical waste is not confined to the hospital. Every household is generating a biomedical waste. In going further, even the sanitary napkins, they are also source of infections. Suppose if that patient is HIV patient, suppose. If she is HIV patient, every month when she is menstruating, she is using diapers. If she disposes to the municipality, if something comes in contact with either patient or rag picker or anybody for that matter, or even animals, it spreads the infection. Even diapers, it comes under the biomedical waste now. All the ladies' hostels, now they are giving the sanitary napkins to us. So the biomedical waste management, that it is spreading almost to all the household. It is not just confined to the hospitals. Each and every house is generating biomedical waste, either one form or other form, because of the diseases. Either diabetes is almost common, cancer is almost common, and birth longevity is increasing. Almost drug consumption is almost a routine practice now. About what I was about to 50 years back, now the drug consumption almost manifold increases. What will happen to the leftover drugs? Especially we are worried about the chemotherapeutic cytotoxic drugs. They are highly toxic and carcinogenic or even injurious to the health. Or suppose your child or somebody's child comes in contact with the cytotoxic tablets or the thing, what will happen? By mistake, if consumes it. You know the toxic effect of cytotoxic drugs because you are the masters. So biomedical waste management is not a simple thing. It is a very serious effect. It is everybody's responsibility. Yes, sir, please. Yes. Correct. Yes. Yes. The outer cover, they have to take it. They have to take it. Allah, see, you have to make sure that Waste also. Even, even last month only, probably you have seen the paper, even the Davangere, in the neighboring district, what, they just come with a big way in the newspaper. How they are disposing the biomedical waste. Forget about the non-biomedical waste. Household waste, we call it as. Still the awareness is not there. It is a very serious and complex problem. It is a change in the attitude of the individual. It took us almost 20 years for us to come to some conclusion now. We started in 2004, now it is 21 years now. We are running the plant. Anything else? Why is important for pharmacologist is whether you practice in teaching or you practice in medicine or you go to the government hospitals or if even as citizens in our house, if somebody falls sick, somebody has got a diabetes or a cancer patient, we can create awareness, you do the scientific method of disposal. Because spreading infection is very, very dangerous, as we have experienced the corona. Corona, we have experienced it. And the next thing what goes is, what we call it as so-called waste, it is not a waste. It is a misnomer. It is a waste misplaced till it finds a suitable user. For a recycler, this is for a raw material for him. For us, it's a waste. For a recycler, it's a raw material. And we have got only one earth. We don't have any other earth. We have to protect our earth. How to protect? It's all our responsibility. If you go to any office, they say, doctor, you are a learned person. If you cannot follow the rules, how can you run the government? You go to any DC, they will tell the same thing. See, you are a cream of society. All doctors are cream of society. And if you cannot understand the significance, how can you make the people understand the seriousness? That's why the definition of doctor comes. It is a friend, a philosopher, guide and everything. Earlier, family physician, what is the definition of family physicians or doctor? Is a guide, friend, philosopher, all those things will come. It's the true meaning of a doctor. Because potential resource, this is a potential resource. Only for the timing it is waste. If you go to the recycler, it is a potential resource for him. We call it a circular economy. If you think about economy, this is circular economy. You should not waste anything. Recycling. That is circular economy. Till it have its useful thing. Anything, sir? Sorry, sir.
Thank you, Dr. Shekhar KB. That's showing us immense responsibility we carry towards safe, ethical and sustainable waste management in healthcare. Now I request Dr. Mahesh GK and Dr. Siddhalingappa CM to hand over the memento to Dr. KB Shekhar.
Just for awareness, this is color coding. This is our Sushuta's color coding practice. And these are the stickers that we give it to all the nursing homes. And this is the recording that we give it to all the hospitals. See here the date and the type of waste, red, yellow and country, and to whom you handed over, and what is the weight, and monthly calculation, And every year you have to give a report, that's annual report to the Pollution Control Board. It is stricter than income tax law. Income tax law is almost you can manage, but not with the biomedical waste rules. And that Environment Protection Act is very, very serious.
He has got clinic and he has got several hospital models.
At the Shumag, I think everybody is having it, I think. If anybody interested, this is a guidelines is there. You can contact me. Anything.
Savya, hey, Ishanna, ಹೇಳ್ರಿ.
I request Dr. Shekhar KB to receive the memento from Dr. Mahesh GK. Photo. I request to take the photo.
ಅದೇ ಟೈಮ್ ಆಯ್ತು.
I request Dr. Siddhalingappa CM to present the memento to Dr. Shekhar KB. Thank you, sir. Now we'll present mementos to our volunteers for their immense work and support in all stages of conducting the conference. Now I call upon Dr. Harika AV. I invite Dr. Abhishek Acharya, Dr. Sushila, Dr. Mahesh GK, Dr. Siddhalingappa CM to hand over the mementos and certificates to our beloved volunteers.
Dr. Triveni NR.
Dhanush Sanu. ಇಲ್ಲಿದೆ ಡಾಕ್ಟರ್ ಶ್ರಾವ್ಯ. ಡಾಕ್ಟರ್ ಮಹೇಶ್ ಬಾಬು. ಡಾಕ್ಟರ್ ಶ್ರೀ ಚರಣ್. ಡಾಕ್ಟರ್ ಸಿಂಚನ.
Dr. Nikhil HN. Dr. Ayush Murthy. Dr. Harshita M.
Support staff, Umesh, Nagraj, Alnas, Prabhakar, Rekha, and all the hospital staff who have helped us in conducting this program, and also the entire volunteering team, and also the photography and the audiovisual team. Thank you for your unwavering support. Looking forward to further other events, not conference, but other events in the college. Thank you, everyone.
And we have missed one name in our conference. Yesterday also we could not tell that name. Dr. PLN Nachar sir. So he has helped a lot. He has given so much input how to manage the show like that. Yesterday we have missed. We could not tell that name. Sorry. Sorry, Abhishek.
Penalty of 10,000 rupees for me. I know, but no, none of the delegates are still here, but thank you to everyone for your support. Oh, sorry, sir. And thank you.
Special thanks to Dr. Narayan Reddy, who is the last delegate, who is still with us. Sir, thank you very much. They are associate delegates. He is pharmacologist delegate. Thank you, associate delegates also.